And you just have, you're going to be NMSU graduates.
Eventually.
You will be, and you're going to pass the PEP. And if you wish, you'll get licensed to prescribe in the state of New Mexico. And you can use that authority to prescribe elsewhere in the military, in the Indian Health Service, in other states, now including potentially Illinois, and quite certainly Iowa, because Iowa's law is modeled after the law here. And also potentially, this is background, Idaho. And although Canada wouldn't want you, unless you're already a Canadian citizen, they actually have standards for which U.S. citizens can immigrate to Canada. It's not like they just want to take everybody. But I think a useful skill would be being a prescribing psychologist. So you might actually be able to prescribe in Ontario, because Ontario is working toward getting prescriptive authority passed. The reason I'm going to be sitting and I'm not going to talk as loudly as I usually do is because I have a virus and my voice is not going to hold up. And so I'm going to just forge ahead, but I'll try not to start whispering before at least tomorrow. And we'll try to talk in a way that you can. We have who online?
We have Jonathan Roman, and I believe, and he can tell me if I'm wrong. Oh, good, they're going to tell you. But I believe he's a graduate of Alliant.
Oh, okay.
And he's watching this in Northern California.
All right.
And Casey McDougall actually taught a segment of this course, and he works on an Indian reservation in northern Minnesota and lives in Bemidji, Minnesota. And Dr. Eversley is he did his graduate, his MS work at Nova in Florida, and he is from Atlanta.
Okay. I think I've met Casey at the APA. I don't know that I've met Jonathan. Jonathan, have I ever met you? Oh, through email. Yeah, okay, I thought the name was kind of familiar. Well, I'm going to first introduce you to the structure of the PEP exam and talk to you about resources for preparation. And then the materials I've provided to you take you through all of the 10 parts, the 10 areas, the domains that are covered on the PEP exam. And what I'll recommend to you is that you may want to print those slides out, put them in a 3-ring binder, and use that to organize your own notes, because I have embedded in my slides all of the APA's record statements about what is covered in each of those domains. So first, the PEP, it's not the only exam that was thought it might be used to credential people for prescriptive authority, but it is the one that is accepted generally in all of the states and in Guam where prescriptive authority has been granted. So this is the hurdle that one must get over. And let me say first that it is not a test of clinical acumen. It's not really a test of one's prescriptive management ability. It is a test that is a fairly deep slice of various domains and the information required to be known in those domains. The characteristics of the PEP are being restudied right now by the APA. It may well be revised. it is unlikely to be revised soon enough for any of you to benefit from the revision. So what you're going to be dealing with is this current iteration of the PEP. And it has itself been revised from the initial form. And the second form, which you're going to be presented with, is only a little different than the initial form. And I'll describe to you what the differences are. I just mentioned that there have been, at least through December 31st, 421 administrations of the PEP. Now that's not 421 different individuals, because there is about a 50% pass rate, and it is possible to take the test 3 times before you must then go back and take some mandated supplemental education before you can retake the test. I have not polled people, and as you might guess, we're psychologists and we have fairly high standards for ourselves, and a lot of people are not real comfortable with announcing that they took and failed the PEP. So I can't tell you, actually, anything about how many people, because it hasn't been published, how many actual people this represents. The average score per administration overall is 106.5. The overall average score being 106.5, there are alternate forms of exam, and there are only 2 of those. They're weighted slightly differently. And so on one form, you pass if you get 69.5% right, and on the other one, you have to get 71% right because the items are weighted. But you can figure, when you take the exam, that if you've gotten 71% right, it's almost a slam dunk that you will be told by the college at the APA that you have passed the exam. You don't know for certain that you passed until you get the letter from them that verifies that you passed the exam. You don't know when you take it which form you're given. And on any given administration, approximately 50% of the candidates pass. And I can tell you that I'm pretty sure that if all of you, if you just had to take it today, half of you would probably pass the exam with the preparation you have. What preparation would you have for the exam? Well, the exam's over everything you've studied so far. So you've already been preparing for the exam by taking the curriculum and listening to the lectures and doing the assignments. And so the refresher study you're going to do will review things to kind of refresh your thinking about what it is that you've learned and to reinforce some concepts and maybe clarify some things. But it's a matter of really reviewing what you've already learned in order to pass the exam. So the published materials from the APA, and I've provided those to you as supplemental material, copies of all of the published material from the APA about the PEP and about what the knowledge areas are. And so the best guide to what's on the PEP is what's in those documents, and so that's what we'll follow in our review. And it's important for you to know something about each of those knowledge areas going into the exam in order to be prepared to take it. The knowledge areas, and these are the percents of the items on the exam. Physiology and pathophysiology is 9%, and neuroscience 8%. Nervous system pathology is 9%. Assessment techniques 10%. differential diagnosis 13, and pharmacology 12, clinical psychopharmacology 13, research is 4%, professional, ethical, and legal issues, and your professional issues is 7%, integration is 15%. The test itself, again, is 150 items, 2 alternate forms. It's computer administered, timed. The items call for analysis and judgment, and they may call on information from more than one knowledge area to answer a question. So about 2/3 of the questions are those kinds of hybrid second-level questions. And many items can present clinical scenarios. Each of the content areas that the APA gives you is accompanied by a set of sub-areas. And again, you need to know something about each of those. You won't know what is actually going to be on the exam. And if you think about it, and you think about those sub-areas, and you look at them, and you try to write a question about them, you'll discover, yeah, it's pretty hard to write a question about some of those areas. And actually, as you know, a good strategy for study might be for you to simply go through those materials and write a question for yourself about every sub-area. What might they ask me about this? And that would be a very good review technique for the test. So while you're taking the test, you can mark questions for later review. The software gives you a running tally of the items that you have and have not answered. You get visual continuous feedback about the amount of time you have remaining. It prevents you from answering more than one answer. And you get immediate results at the end. When you push the button done, then it will tell you. And actually it will give you a printout of each of the domains and how many questions you got right. And it'll give you the overall percent that you got right. But again, it doesn't mean you passed. You have to wait for the APA to tell you. But if you got 71%, it's pretty much a slam dunk. When you're in the actual testing situation, the testing session begins with a tutorial. And the tutorial allows you as much time as you want. You can sit there and play with the tutorial and play with the software to make sure you know how to use it, to move back and forth in the items, how to mark items, how to answer questions and mark items for later review. And there's online help available. There's also a testing staffer there who could help you if need be. Now, we've had one person take the test. The power failed, the equipment failed, and so she had to reschedule and take it at another time. This is a very rarely administered exam. So the people who administer it, Prometrics, which is it's the licensing testing people associated with Sylvan Learning Centers. They've never seen this exam before. Maybe in New Mexico, they've seen it 1 or 2 times, but it doesn't exist in their center. It has to be downloaded to them in order for it to be administered to you. And so that's why it has to be scheduled. You have 3 hours. Once you're done with the tutorial and you say start, you've got 3 hours to take the test. That'll feel like enough time. I had enough time to do what I'll tell you I would suggest your strategy might be in how to address taking the test. Okay, we have a sample test, and I have it as a PowerPoint. I don't think I included it in the materials that we distributed, but I'll give it to you to upload. So I've got a sample test for you to take, but you'll take it on the computer, but it's not like the actual PEP because it doesn't have the same software and the same structure and how you can mark items and that kind of thing. And I'm not very pleased with it, but I'll tell you how you can test yourself with items that were developed by the same team and drawn from the same pool that the PEP is drawn from. So although they don't say that it is predictive of the PEP, it probably is. And there are a couple practice tests out there that I think are probably somewhat predictive of how you're going to do it. The software is really flexible when you're taking the actual test. So there won't be a problem with the software. And I would say that from a test construction, clarity of writing, clarity of concept point of view, this is probably one of the best exams I've ever seen. That doesn't mean it's any good in the sense that it is predictive of clinical ability or clinical acumen or safety as a prescriber. That's different. But the questions are not ambiguous. They're clearly written. And so it's a very well written test. It's just flawed concepts in terms of what should you be tested over before you are declared competent with regard to the knowledge base to prescribe. But we can't do anything about that, so we have to live with it as it is, and it's a hurdle, so you get over the hurdle.
DC has a question.
Yes.
And it says, are the sample tests in the CD-ROM of the Handbook for Clinical Psychopharmacology for Clinical Psychologists, that's the Muse book, reflective of the PEP?
I would say yes. If you are getting, and I have an N of 1 of a psychologist who used the Muse tests and continued to test himself, and he waited until he got 75% on the Muse test. That was when he triggered himself to go take the exam. And that was his trigger. And he passed. And passed with a score pretty equivalent to what he'd gotten on the Muse exam. The problem, of course, is the Muse exam is a limited set of questions. And the second problem is that you don't get feedback on individual items and what you did wrong, or what was wrong, what would be right. And I'll give you a resource that will really do that for you. It's a modern resource. And we'll come up with that.
I got a little bit of feedback. You can find out what the right answers to the Muse and More test is. Like, you just look at the code, and it tells you which right answer was on each one. So if you really desperately need to know the right answer to a question, like you just feel a burning passion, you can still find out.
Okay, what they think the right answer is. And what Mark Muse and Brett Moore think.
What they're scoring you at.
Yeah. And I think you'll find, and maybe I certainly have found, that I'm not always in agreement with what somebody who constructed a test thinks that's the right answer is. Because there's some of the answers here are somewhat debatable. Okay. So the first content area is integrating clinical psychopharmacology with the practice of psychology. And this is what the APA says is the general explanation there of that area. And I'm not going to read all that, but here are that's the general category, and then here are all the sub areas. And so as we move through this review, we're going to address most of these. I guess we'll probably address all of them. And so you can use this first PowerPoint and print that out to organize your notes for going through and put it in a 3-ring binder to organize your notes in order to supplement what I'm giving you with going back to see what your books say, materials that you're not so familiar with, things you need to understand. So the remainder of this PowerPoint is simply the restatement. I mean, it's copying those items. All right? So the next PowerPoint, and Saj, I may need help. Casey says, also, but nothing else. We lost you, Casey. Did you have a follow-up to the word also?
Oh, I think he was correcting a typo.
Oh, okay. All right. Is this 1.1? Yeah. For those of you out there in following land, we're getting booted up here. Okay. If you want to link to the APA's materials and look at that, and if they put anything else up, that's the link right there. And if you put the slides into the project mode, then the links will be live and you can just click on the links. And I've tried to make sure all the links as we go down through this are active. Prometrics with Sylvan Learning Centers are the people who actually administer this test. They administer the EPPP, they administer the med-level exams, the pharmacist exams, a lot of professional exams are administered by Prometrics. I think I have the most recent pass rate information, which is the 2014 stuff, which we'll look at a little bit here. You can link to a PEP practice exam, and this is what you were asking about, is this test track developed the test. They are the construction experts that put the test together with the consultation of the Blue Ribbon Committee from the American Psychological Association as to what content should be included. And they pulled 75 items out of that pool and created this sample test. So it's half as long as the PEP. But it is, and it's when you pay your fee and take it online, it doesn't have the same nifty kinds of features in terms of the software management, but it's a way to test yourself on items that are very, very similar to items on the PEP. So if you take this and score more than 71% right on it, then you can probably guess that you are in the ballpark. You score 75% on it, you probably have a real good shot at passing the PEP. But again, they don't make that claim, but I'm telling you what people have told me who've been preparing and who've tried various techniques of preparation. I myself did take this, and I retook it recently because I hadn't looked at it in a while. And yeah, I thought it was pretty difficult. And I've been at this a while. And so I would suggest that using the Muse, using this as ways to kind of grade yourself about readiness would be two good tools to use. You can go to that website, you register. This gives you information on what you have to put in to actually get to the point where you can pay your fee online with a credit card and then take the test. Now, this is 2016. And let me explain what this means. What I did was to take each domain area. I'm trying to calculate everybody that's taken the test by 2006, which area do they have the most difficulty with? And I can explain how I derived the numbers in the last column, but I don't want to wear your patience out. And the short story is, if you look at the last column, the average person on the average administration, with regard to integration of psych and RXP, that's the first category, 100% of the people, okay, the average taker, the average of all the takers was enough to get 70% right on that category. And then with regard to neuroscience, the average taker, the average of all the takers' scores was only 93% of what it would take to get a pass on that area. So this is a way to show you, of the people who took it by 2006, what were they having the most trouble with, and what did they have the least difficulty with. And so you can see that they had the least difficulty with pharmacology and clinical psychopharmacology. That's the stuff you like. So you probably need to spend less time reviewing the drugs, the features of the drugs, and how pharmacology works, pharmacokinetics, pharmacodynamics. That stuff you probably know fairly well. The research, I'm a little surprised that the research is only 110%, but because we got a bunch of PhDs who've done a lot of research. So I would think that this is weird research. The pharmacology research is a little weird, and the questions are a little off what we do classically in psychology. But the biggest problem is physiology and pathophysiology. Next biggest problem is nervous system pathology, and then neuroscience. So those are the areas where the average person, the average score was not enough to get a 70% on the test. So if you're going to take the experience of others as what to focus on, then unless you're a nurse, pathophysiology. Unless you're a neuropsychologist, neuroscience, and nervous system pathology. The medically trained people do better on pathophysiology. Why? Because they know pathophysiology. The neuropsychologists do better on neuroscience and nervous system pathology because that's what they've lived with. And so they sometimes blow the top off that section of the test. Okay? Now you yourself, of course, you have to kind of analyze yourself and know what your strengths and what your weaknesses are. And that's why those practice tests may help you identify, okay, what do I know better, what do I not know so much about. So, and this is again commenting on that 75-item test track test. Now here, you know about Muse and more, and although I'm telling you, you can sort of use these as an indicator, none is really a valid predictor as far as we know. We have no validity studies on that. And although I had the best of intentions to ask people to take the test track test, pay the $75 after they'd taken the PEP, and tell me what their PEP score was and what their test track score, but it cost everybody $75, and so I never did that piece of research. Okay. So I'm reviewing ways you may want to review, but I would say the best right now test item bank for you to use is fresh and new, and there will be a new version of this coming out in the fall. And this is the Spiegel and Kenny Psychiatry Test Preparation and Review Manual. Okay? Now, remember, it won't have much pathophysiology on it. And it will have items about basic psych diagnosis and primitive questions about counseling and psychotherapy, because this is psychiatrist board exam testing preparation. However, it is a large pool of modern items with a lot of pharmacology, clinical psychopharmacology, ethics. By the way, the psychiatrist ethics are the same as ours. With one exception, they're more stringent. They're more stringent on a physician may never participate in interrogation. So, I mean, they're prohibited from participating in interrogation and in any procedure involved with the criminal justice system meting out punishment, so they may not participate in executions, that kind of thing. So they have that one feature that is even more prohibitive than our ethics. The rest of the ethics it's the same stuff. So the advantage to this particular test item file is you go online and you can ask for sets of questions on various domains, and it will give you immediate feedback with information about why an answer is the best answer. So of all the review materials, I think look at Mark Muse and Brett Moore and that test item file if you can hack it and figure out what the correct answer is.
It's just clicking on a file and then it opens it up.
But for really getting information about why an answer is correct and why it's not, then I would suggest using it. Okay, let me see. I've talked about this stuff already. Okay, what do they say? A lot of people complain that the items are not recognition and recall. That would be easier. And only about a third of the items would be considered recognition and recall. And 2/3 are a higher level of abstraction. It's know 3 facts and make the best choice, the best decision about it based on those facts. It does supposedly test reasoning and clinical judgment, though I think that's really unlikely. You don't need to have the details about all of the drugs memorized. It will include TCAs and neuroleptics. It will include older medications. Now remember, one of the things that the team 4 years ago did when they reviewed the test was they were adding questions related to cultural diversity, which they discovered they really couldn't do, and later I'll tell you why. And secondly, they went through the test item file and threw out what they thought were bad items. And they updated slightly the formulary. But you're not going to see, it's unlikely Vyvanse is going to be vilazodone. It's unlikely it'll be on the exam. It's too new as a medication. So there are medications that have come down the pike that are going to be too new. And it's going to include first-generation antipsychotic questions. It's going to include lithium questions and carbamazepine, old mood stabilizers, and the tricyclics. So there will be questions that are centered about 8 years ago, 8 to 10 years ago. And so that's really the knowledge base that's being tested is about 8 to 10 years ago. Now, why did they have trouble writing questions with regard to ethnic and cultural diversity? Because it's very crude to say that, well, Asians have a propensity, a higher percent of them have problems metabolizing 1A2. Well, we don't know whether this person of Asian descent does. Who's an Asian? And so we're on the cusp of going to individualized medicine where you don't make an attribution based on somebody's named ethnic background or what you presume is their genetic background. But you actually test them to see what genes do they have with regard to the metabolism of medications. And most of the genetic diversity stuff now is looking at just pharmacokinetics and differences in pharmacokinetics that are based on individual genes. We don't have a lot of knowledge of genetic diversity with regard to pharmacodynamics, how somebody with a particular set of genes differs in a response to a kind of medication versus another set of genes. Plus, there's epigenetics, and there is which genes are turned on and which is turned off, and the complexity of environment-individual interaction. So, to write crude, overarching questions when we know that's a very crude index, all it does is say, well, you better remember there's a possibility that since this person clicked the Asian box, that they may be a slow metabolizer of this particular system. But writing questions that would have intellectual integrity was just too difficult. And so they really failed in their task to introduce better questions on the cultural diversity. Now, okay. What I would suggest when you take the exam is this process. Read the instructions about how to use the equipment. Actually, I would tell you that I was so nervous, I registered and then I went to the place and looked it over before I was to take the test to kind of desensitize myself. I wanted a mental picture of where I was going to be going, where I was going to be sitting, so I could go home and I could practice taking tests and I could visualize. So, okay, it's the day of the test. I'm going to take this test timed in 3 hours, and I'm visualizing walking in, being there, having them strip me of all writing implements and anything to record, and my wallet, and they lock all that stuff up. You're in there. You're lucky they leave your clothes on because they want to make sure you don't walk out with written down items, because you know there would be quite a market for in professional licensing exams for the actual items that appear on the test. So I'd recommend going there, because then that allowed me to visualize that as I was trying to desensitize myself. Because I anticipated I would be somewhat anxious, and that is probably an understatement, and I think most of you would feel the same way, or will feel the same way. So do what you do best in the way of centering and desensitizing yourself to the testing process. And that's usually taking sample tests in as close to real live circumstances as possible. And even if you have a friend who's going to be your test administrator and you're going to report your score to them at the end of the 3 hours, anything to increase the stakes a little bit to get you desensitized to the process of doing it. So read the instructions carefully, complete the tutorial, really make sure you understand how to mark your answer. Now read each question and all the answers carefully and completely before you select the most appropriate answer. This is just standard test-taking technique. Most of you know this, but I'm going to review it anyway. Your task is to identify the best answer among those given. In a few cases, more than one answer may be workable. You have to decide which is best. And try to manage your anger at the test. Because I've had a couple people saying their biggest problem was they got so angry at there being 2 questions that seemed closed that they really just couldn't deal with the fact that it wasn't a recognition and recall with a clear set of bad answers and one good answer. When you choose an answer, resist with all of your might changing it unless you're absolutely certain that it's not the best answer. And usually the only excuse you have is you realize when you reread that you misread the question. Would be the only excuse you have for changing an answer after you pick an answer. Answer all of the questions. The 2 hours or the 3 hours are going to be enough. But keep an eye. There's a running clock on the computer screen, so you can keep an eye on how much time you have, how much elapsed time there is, and how much time you have left. If you have time remaining when you reach the end, return any items that you skipped. So you can go through the test without answering anything. You can go through the test and answer items. You can go through the test and answer items and also mark items at the same time. And then you can go back and look at all the ones you marked. You can look at all the ones you haven't answered. You can look at just the ones you've answered. Or you can go from the beginning to the end of the test again and read every item. So you can move back and forth that way. I've said all that before. Now, here is my absolute best strategy for you folks. I know what I said about the test track, practice test, and mark views. I strongly recommend, you're graduating, right? Saturday? Okay, you'll be eligible. Are they eligible to go take the PEP? You graduate Saturday, you're eligible to take the PEP. Register for it now and take it diagnostic. Really. You may not have to ever take it again. There's a good chance some of you will have passed the test. If you get 71%, you're done. You no more bull. You're done. And you only get over this hurdle. It isn't a measure of your worth as a clinician. It is just a hurdle in your way. And so take the thing diagnostically, because then it'll give you feedback and it'll tell you what to study. Don't waste a lot of time studying stuff you don't need to study. And just study the areas that you didn't do well on, and then you take it again in 6 months. It's going to cost some money, but how much money does it cost for you to, rather than see patients, study 400 hours rather than see patients? It's costing you a lot of money to not get this out of the way. and to be studying if you don't have to study. You're not going to learn to manage medications till you start doing it anyway. And this is an obstacle to your getting to start managing medications under supervision and to learn how to really do it, how to really be a psychopharmacologist. So I know you're all psychologists and you're all perfectionistic and you can't stand the idea of not passing an exam. Don't tell anybody you're doing it. Just do it. Yes.
So does the board get information on how many attempts?
No.
Or they just get pass-fail?
As far as I know, all they get is a report of your score. And the APA sends them your score from the PEP, and all you have to do is have a passing score and your license. And I've never heard anybody who had to take it twice say, oh, I'm embarrassed that the board saw that I didn't pass it the first time. But you need to understand physicians. There are all kinds of physicians out there that have had to take a medical level exam 2 or 3 times. It's not a loss. You're not going to lose status in anybody's eyes if you take this and don't pass it. And so take the thing diagnostically. Some of you, probably, I'd say close to 50% of you will pass it. And you're done with that, and yet this bowl is over. And then you can go on to learn how to actually manage medications and get licensed and go on with your life. Okay?
How many times can you take it?
3. And then you have to take some remedial, then the APA College of Education gives you need to retake. Well, we looked at your scores and you're having trouble with this, so go take a course in X. And then, or some CE in X, and then come back and take it again in a year. So
6 months per?
Pardon?
6 months between?
The first and second, I think, is 6 months. But it's going to take, if you register to take it, it's going to be weeks before you can get to take it. So you got that time to study and review. And then take it diagnostically. Because some of you are going to be studying this, you're going to be obsessing about it and studying for a year before you take it anyway. May as well take the thing and then know what to study, and then some of you won't have to even do that. Yes.
So there are 2 forms.
Uh-huh.
Take the first one diagnostically.
Yes.
The second time you take it, and I'm presuming I would not pass the diagnostic version, you're going to get the alternate.
We don't know.
So it may or may not be. It may be the same one.
Yeah.
And then if there were a third attempt, then it would go.
Yeah. No, there aren't that many. There are only 2 forms.
And
So you're
then
getting one or the other.
the revision, when would you project that to be?
Well, they're formulating the APA, the underfunded APA, is considering structuring the committee at this time. So I would say they'll meet in 2018, and they'll quibble till 2020, and then they will assign a committee to revise the test, and so I'd say 2022, well, you might see a revised PEP. I haven't yet been asked to participate in revision. They may not ask me, but they might. So I haven't heard. They would ask me who I thought ought to.
Well, what's kind of blowing my mind is that there's been, 421 administrations of the PEP, and half of those have been fails. So we got 200 and something passes of the PEP to this date, to this point. That seems really low.
Yeah, it's ridiculous. Well, we're talking about doctorally trained people. Only a test that's flunking half of doctorally trained people that have spent how much time studying this stuff? So I'm not defending this. All I'm telling you is practically, don't tilt at windmills. Just be practical. Register for it. Study and take the darn thing. And figure out what you need to study so you can be more efficient, so you don't lose a bunch of clinical money studying a bunch of stuff you don't need to study. Okay? Yes.
The materials that you had mentioned before, specifically the Spiegel and Penny,
Mhm.
there's a new version of that coming out.
The old version's perfectly good because the new one will have new medications that aren't going to be on this test anyway.
Right, and they're not going to revise the
test.
current tab.
Yeah.
The new one's out already.
Yeah.
This
Oh, yeah,
is
it's
a
already
second
out this
edition
way.
right here.
But I like his idea of getting the older one and studying for the test
No,
we're taking.
this is.
You want whatever, you want to be able to go online and just take tests,
Right.
take sample tests. You want to be taking as many sample questions as possible in preparation for this test. And then if you don't know the answer, you need to be able to find, okay, what is the information? What do I need to know in order to answer this?
One of the recommendations I heard was to take a certain number of questions each day. So like take 20 questions a day or something like that and understand those questions that you take.
I think everybody's learning style is a little different. That sounds like a perfectly legitimate way to proceed. But you know how you study best, so do that, do whatever it is, but take the thing diagnostically right away so you'll know what you got to study.
I really like that suggestion, taking it diagnostically. So when I get feedback,
It's just diagnostic.
when I get feedback of, didn't
You were gonna pass.
Pass.
Oh my gosh.
diagnostically. How will that feedback look? And the only thing I have reference to is like the EPPP, pass fail type of thing. It doesn't give you a breakdown of, neuroscience, this.
The feedback I got when I was done gave me each of the domains with the number of items right in each of those domains.
And how do you collect that information walking out if you
They
can't-
print it out for you and hand it to you.
Okay.
So you get a printout even of that.
That's what happened to me when I left.
So the strategy at that point, you have this printout, you know the domains of areas that you need to improve upon. From that point, is it going back to using more, the Spiegel and Kenny and other online tests?
Well, no, I think then you would say, okay, I need to do some background reading in that. So I'm going to go back to that portion of the materials. And I'm going to study, I'm going to review all of that stuff. So if it's pathophysiology, you get the big graduate textbook and you read the pathophysiology textbook. And then you do more of the questions, the online questions. So you actually do a more intense background study in that area.
So the likelihood of doing that, and so you go back and take it for real, the percentages of each domain may be different. So
Mhm.
everything that you really focused on from the original feedback, is it going to be different on the second?
Well, it certainly will, just from a sampling point of view. But, so I wouldn't abandon reviewing, doing online items. I would continue to do online items to stay fresh on the other stuff, but I would really focus on that area. Yeah. Okay?
You just see my face.
I can't, I must say I can't promise any particular strategy is going to work, but I'm just trying to tell you what I really would suggest that you do. Okay? Now, on the test day, I'm saying what you should do is quickly go through the exam and answer only those questions you're sure that you know the answer to immediately. So that's what I did, and I was a little disheartened to discover I only had about 1/3 of the items marked when I just answered the ones that I thought I knew for sure. Then I went back and guessed at the items that I hadn't answered, but then I marked the ones I guessed. So I had marked items that I thought I knew for sure, and then I had items that I'd answered that I knew for sure, and then items I'd answered and marked that I was guessing, and there were still blanks. And then I went back through, and the ones I hadn't answered yet just guessed. And then I went back through slowly the exam, reread every question and every answer, and took the marks off. And then I pushed the quit button. And then I let out a kind of yelp of glee and discovered that I had really violated the rules of the testing center because there were other people taking exams. And what I had done was disruptive, and that the test center administrator let me know in no uncertain terms that I had misbehaved and should feel ashamed. And I tried to not smile. She was reprimanding me because I was so happy to see that percent. Okay, you are to prepare for the test. You're reviewing the material. You've studied this stuff. It's going to be on the test already. The single best book. Oh, here's another good PEP review, but PEP review, test item bank, but I still suggest the first one I told you about. The Mass General one, it's a big test item bank. Again, it's for the psychiatry boards, so remember that's skewed away from pathophysiology, and there's too much baby psychology in it, but it has a lot of the other areas are well covered. All right. Okay, I've talked about this already. You need multiple exposures to them and trust your quote-unquote unconscious. Remember that the research indicates that your guess is going to be biased by something you read that you don't remember, so that your guesses are not read. And so, rather than try to memorize everything, you need to review this as much of the material as you can repeatedly, so that you have that sort of exposure base that is going to inform your guesses on this test. Another thing is, if you have any opportunity to teach some of this material, that's a really good way to learn. And John Andazola last night, as we flew in from Chicago at midnight at El Paso, the residency director and I and two other people presented in Chicago yesterday in El Paso. And he asked me what I was doing today because I told him I couldn't be in a meeting this morning. I told him in 3 days of the PEP review, he said, you're the only person that learns anything from doing that. Students don't learn anything. You give day-long lectures, they don't learn anything. That's why you know so much about psychopharmacology. And those poor students are going to have to sit through that 3 days of that bowl. And he said, it's a lousy way to teach. And I said, come on, this is not easy to do. Don't do that to me. I've got to gut out 3 days of doing this. So don't tell me there's no point. So I'm going to hope that there's a point, that you're getting something out of the review that we're just about to begin. But if you can find ways to give brief presentations, especially on the material you know least well, that's arrange a lecture for yourself, or a presentation, or a CE or something, is a way to really get the material burned in. You pair it with anxiety. If you have to do a presentation, you're going to pair what you're learning with anxiety. You know, anxiety-paired learning sticks. Pair it with anxiety, it sticks better. So trap yourself into having to do a presentation on the material you know least well, and it will be burned into your brain.
We could do it for each other.
You could.
Like key learning groups,
That's right.
where you can teach each other
During a break, you can organize that. I'm not going to stand in your way. I hope that my presentation doesn't stand in your way of learning, in spite of what Dr. Anderson said. I'll get him. Examples of overlearning.
I've got a question.
Yeah.
On any of the practice tests, does it break down content areas that you're doing poorly on, or is that only through the main taking of the PEP that it breaks it down that way?
The only practice test, or the only way to get a practice test that does it is to take the PEP diagnostic.
Diagnostic.
You can sort of do it with this reference I told you, because you can pick areas.
Okay.
And you can see, well, how do I do on this area versus that area? You can kind of test yourself.
And that was the one that went around, or that was the one?
That's the one that you passed around, right?
Yes.
Yeah, okay.
And have you been online on that?
No, I haven't.
Not yet? Okay. And that's going to happen this evening, no, Monday, right?
Yes.
Okay, good. So, some overlearning is helpful. Which neurotransmitters operate at G protein metabotropic receptors versus ionic? GABA B operates G protein. GABA A operates ionic receptors. Organs stimulated by acetylcholine. So here would be an example of a PEP item. The parasympathetic branch of the autonomic nervous system is most involved with which neurotransmitter? Is it A, dopamine, B, norepinephrine, C, serotonin, D, acetylcholine? This is just a recognition and recall question, and that's one kind of question that we have. So what do you think the answer is? Is it A, B, C, or D? What is the neurotransmitter that is most involved in the parasympathetic branch of the autonomic nervous system? Acetylcholine. There you go. Okay, you passed the PEP, you may leave.
Yay.
Yes, get it in writing.
Okay. All right. Make your own tables. Start a desktop file. By the way, on the test, you're not going to be required to have memorized all of the generic and trade names of all the medications.
You'll give them both?
My recollection is they give both or give generic. Gave you those formulas. I'd also suggest Rita Carter, The Brain, huge color plates, detailed neuro review, and again, this is because of the neuroanatomy, and this one is very useful with regard to brain pathology. So these two are very useful in the review in the two areas that are most difficult. And a special note, the Content Area 3 differential diagnosis, it doesn't have anything to do with that, really. It has to do with understanding about 30 medical disorders and both psychological and physical symptoms. You must know Mass General inside and out on this. Since you simply cannot memorize all of this, pick out 2 to 3 cardinal features, or just one if possible.
Do you have the list of those 30?
It's in these groups. And I'm reviewing where the practice questions are. The real questions on the PEP have only 4 choices. There's almost no A and B or all of the, it's written better than that. It's one answer is the best answer. And it's not A, B, and C or A, B, and D. Okay. Now, the genetic racial polymorphisms. I talked about that as primarily the looking at the pharmacokinetics related to the SIP system. So if there are any questions on genetic polymorphisms, then it is related to the SIP system. So then I have possible study timeframes here. This was put together by my colleague, Leah Billington. She did not take my advice. I have trouble getting people to, so please, I won't spill the beans, but if you decide to take my advice on that, let me know how it went.
It's expensive.
Yeah, but 6 hours of therapy. You miss 6 hours of therapy and you paid for the, you're going to miss how many hours of doing therapy or clinical work studying for this thing if you don't do it? It's a bargain.
And I'm not as convinced as he is that I would have a half chance of passing.
Use your best CBT. Use your best CBT techniques on yourself. Anxiety, remember, anxiety management and anger management are the two biggest emotional issues related to taking the test. Challenges. I expected times like this, but I never thought they'd be so bad, so long, or so frequent.
Motivational post.
So now we're going to take a 15-minute break. Isn't this button? I blew this up so I could see it better. And
I've had 2 opportunities to blow up, but nothing related to me. I had an opportunity to get out of my hours to go to jail. The jail program just exploded, so I can't do it. And now they're doing new construction to create alternative units for themselves.
it doesn't like that. Okay, well, we can leave it smaller. I can see
The woman
it.
who works for me runs a jail site.
That's better.
San Francisco for her husband. Family practice. And he's got a big taste of the city. Get my 80 hours done, and it gets a lot.
It is just
Where
funny.
his practice is, a lot of hospitals like around into places, so he's got primary site of the mercy of the city. They're just not welcoming of that, so he's willing, but they're not. I could do my hours with Jewish.
Right, Christine Bento.
It's so conflicting because I'm in contract negotiations with the medical director.
Joe does.
So
She can't.
the ethical.
Christina left.
So
I believe Lynn had to step in. She's just.
Actually, she just doesn't do it. See somebody you think that they might benefit from that?
Someone is requesting. I think she just wants the mental. They ran an initial search.
Good.
To a psychiatrist.
Hey, thank you.
So they don't have.
This first area is the first area is integrating clinical psychopharmacology with the practice of psychology. It refers to the implementation of the clinical practice of biopsychosocial assessment, multi-axial diagnosis, treatment, including pharmacotherapy, in the context of the complex of factors that influence functioning. If we really cared for the customer, we'd send them somewhere better.
I love these demotivational
Yeah, there you
posters.
go. General explanation. These factors include the biological, which is genetic, gender, age, disease. psychological, cognitive, emotional, dynamic, motivational, behavioral, psychosocial, gender, cultural, ethnic, interpersonal, and ecological environmental factors. The first subcategory is knowledge of biopsychosocial variables as determinants of medication effect, including family history. Well, what do we know about family history with psychopharmacological agents? Somebody speak up.
It's work, they may learn.
That's correct. Differential family medication response, same issue. Patient belief systems. What do you know about patient belief systems affecting medication effects?
If they don't believe in the meds, they won't take it.
Well, if they don't believe in the med, but they take it, what? Tends to be a nocebo, tends not to work as well. Sometimes the medication is effective enough it will overwhelm their negative set, but it usually takes longer for an onset of action in somebody who's prejudiced. Economics, social support, current environmental circumstances. So side effects tend to be more similar among biological relatives than related individuals.
And that's both the culture and the biology, right? So the family belief systems about medications, nocebo, placebo.
That's right, but I'm talking here more about the biological here. And the research indicates genetic predispositions to differential rates of metabolism of medications. It's usually the CYP P450, the CYP 450 system. And also the absorption and what happens in the GI system, because there is metabolism in the GI system in the gut itself as the medications are transported across. We see CYP differences in the hepatic system and the P-glycoprotein systems in the gut. Now here is this is sort of a classic chart of expectations with regard to Caucasians and Asians. And PMs means poor metabolizers. So this is what I said was the way we used to do it, and it's very crude. And now, at least, it's possible to swab somebody's cheek and actually see whether they, in fact, bear a particular genetic set that is going to affect the rate of metabolism of the medication. A little more about the nocebo effects. The patient's expectancies impact adherence. There's a big issue with regard to stigma, that in some populations, the idea that you are suggesting that they take a medication is stigmatizing in and of itself. And that some people will take the need for medication as a declaration that they are mentally ill, and they will very much resist the idea of medication precisely because they don't want to wear that kind of a mask. And then positive transference certainly affects the patient's response to medication. And let me remind you, all this work you're doing in psychopharmacology and all this work you're doing to become a prescribing psychologist, I just want to remind you it's very difficult to tell the therapeutic effect from the placebo effect in almost all of the medications we prescribe. So you could get almost as much good handing out placebos as you do handing out the active pharmacological agents, without bearing quite so much a risk of untoward side effects. However, placebos also have negative side effects. And so you'll see side effects rates related to the taking of placebos that come close to the side effects of taking a medication with active agent. Short-term costs of the medication versus other forms of treatment may create a bias for medication as an alternative. Well, what does that mean? It is actually cheaper to just give people antidepressants than it is to give them 12 sessions of CBT. Because 12 sessions of CBT is going to cost $1,600. And 12 months of fluoxetine, 40 milligram, is going to cost $60. So it's a lot cheaper if somebody will respond to a medication, to give them a medication if the medication works as well as CBT. And if you look at the studies, head-to-head studies show that the efficacy of antidepressants is equivalent to the efficacy of non-biological interventions, CBT, interpersonal, the empirically validated methods. So on the one hand, we want to use those behavioral and non-pharmacological interventions because we're psychologists, but remember that part of the reason we're awash in psychotropic agents is for many of the older agents, it's a whole lot cheaper than psychotherapy. A year of psychoanalysis is a very costly enterprise. A year of weekly sessions with you costs the insurance company $5,000. And a year of managing the fluoxetine, and fluoxetine alone, just managing it, is one initial evaluation session, a follow-up in 2 weeks, and then monthly follow-ups. And the cost of the medication, it's 20% the cost of a year of psychotherapy. So that's why, we're fighting a noble battle to try to keep the balance tipped in the direction of non-pharmacological intervention. But then the other side of it is, they don't work that well. They only work ever in 2/3 of the cases. There seems to be this ceiling you hit with all psychopharmacological agents at about 66% response rate. And to get more than 2/3 of the people effectively treated, doesn't matter what you do, adjunct, switching, all that stuff, you may be able to get it up a couple, 3% more. But there seems to be something burned into nature, just like the bell curve is burned into nature. There's something about that. 2/3, 1/3. Stuck right there. So, anyway. Cost and resources. By the way, well, I'll say one more about this here. You know that we are in the state that has the greatest rate of child hunger in the United States. We are in the poorest section of the poorest state in the United States. And we're going to have to be prescribing the $4 a month medication. And ethically, if one of those will do, it's better to prescribe that than the higher dollar one, even if the insurance company will pay for the higher dollar modern Cadillac, because we're placing an additional burden on the healthcare system. So the ethics, that's part of our ethical responsibility, is to think about the impact on the system and the community and the population. So here's haloperidol, $4. These are the first generation antipsychotics. Yes, I prescribe low doses of haldol in lieu of Geodon because it's potent, it's effective, it causes extrapyramidal side effects, so they need to take some over-the-counter Benadryl often. But you can get over-the-counter Benadryl and haloperidol, and that's a quick and dirty. you take on the burden of neuroleptic kinds of effects long term. But it's a risk-benefit analysis. I don't like, I have like 4 textbooks that UMass included. Okay. Oh, they're having a discussion between each other, it looks like. Okay. Well, if we need to address something there, you'll let me know, right? Social support and social discouragement of treatment options impacts the adherence. And the social support of the patient itself is predictive of a positive outcome. We know that the people who kill themselves at the highest rates are older white males with no social support. And the social support is a huge predictive factor in mood in all generations of patients. Inverse relationship between social support and stress. And socially constructed expectancies for treatment outcomes have an impact which enhances the placebo. By the way, ethically, you can say, I want to mobilize the placebo effect when I give this patient a medication. I think I've talked with you about this before, haven't I? When you hand out that medication, you don't want to diminish the likelihood that the person's going to benefit from it. So you don't want to say, this only works in 2/3 of the cases, and you may develop side effects and want to go off of it. The thing you can ethically say is, if you actually believe enough in the medication that you're willing to prescribe it and take the responsibility of exposing the person to the possibility of benefit and harm, and you believe that most people who, like this patient, have the characteristics that mean that they would benefit, to say most people find that this medication helps them, is an ethical way to mobilize the placebo effect without guaranteeing to the person that they're going to do better, and without undercutting the possibility that the patient will do well, but mobilizing the placebo effect, because you want both the biological and placebo effect working if you're going to undergo the responsibility of and take on the risk of prescribing. Cultural competency. This is a little dated, but remember, we're talking about the PEP. Look at the Surgeon General's report, Cultural Race and Ethnicity, that report, and Health Disparities Study. Knowledge of relative effects of pharmacological and psychological interventions as the sole additive or interactive treatments for given disorders. And we'll go through several references here to review what they say, reminding you that there's not a lot of really good research on head-to-head, random controlled comparisons of pharmacology and psychotherapy and the combination of the two. Salmon's book is older. You know who Morgan Salmons is. One of the first he was one of the first DOD prescribing psychologists. He's now the president of the National Register of Health Services. And Dowd and Januzak. And Januzak is a high-riding psychiatry professor in Illinois. Very well known, knowledgeable, published a lot. He's kind of a piece of work. But he's published, and his studies are pretty solid. You also could think about the self-efficacy literature and locus control. And we have clinical lore with regard to what works best for what conditions. Knowledge of the limitations and value of single treatment modalities combined interventions, medication employed alone or in conjunction with psychological therapy, and patient perceptions, attributions of therapeutic and adverse effects, psychological meaning of medication, motivations, and treatment expectations. So, are there conditions for which either medication or psychotherapy is most effective as a sole intervention? And are there conditions for which a combination of medication and psychotherapy is most effective? So here's a reference to Morgan's book. Here are the common sort of anecdotal assumptions. Medication as a sole or primary treatment in schizophrenia, organic psychosis, disorder, in other words, disorders with a clearly demonstrated organic pathology, which responds to pharmacotherapy. Then the combination of medication and psychological treatment for affective disorders, generalized anxiety, personality disorders with a strong affective component, and then psychological treatment, sole or primary for adjustment, chronic personality disorders, panic disorders, specific phobias, and what is the evidence base? More is known about the efficacy of the timing and sequencing of treatments with regard to their method of action when considering the anxiety disorders when compared with this is a chart that shows theoretically that if you look up the left side, how accessible is the patient to psychotherapy? And if you look across the bottom, then it is how much symptomatic distress is the person experiencing. And the left column is whether the drug effect, whether there is a drug effect or not. And so what this is showing is that it is important, there's a sort of peak or optimum range where the symptomatic distress is at an optimum level, and a psychopharmacological agent can take somebody to that level so that they are then available for psychotherapy. And if their symptomatic distress is too low, they're not going to be a candidate for psychotherapy. And we know that about, before we were psychopharmacologists, we knew that you had to have an optimum level of anxiety in order to benefit from psychotherapy. That without the optimum level of anxiety, you weren't motivated enough to participate and engage and dig in. And one of the issues is, do you, by administering a psychopharmacological agent, take somebody out of the zone where they have enough distress that they're willing to work in psychotherapy to learn what they need to learn? Multiple studies show that the patient's preference for psychotherapy is higher than for pharmacological agents. It's about a 2-to-1. So what you're learning to do is what a third of the patients prefer. And you already know how to do what 2/3 prefer, which is psychotherapy over medication. And again, if you decide, in deciding what to use for somebody, patients tend to get better if you give them what they want. So if somebody wants psychotherapy only, they tend to do better if you do psychotherapy only. If they want pharmacology only, they tend to do better if you at least give them pharmacology. So you've got to persuade them to undergo optimum treatment against their preference for a particular kind of treatment if you think it's essential. So there are times when I will say to a patient, yes, I understand you prefer to do this with psychotherapy alone, but I think you would suffer a lot less. And I've seen a number of people able to benefit more from psychotherapy and have a greater quality of life if they respond well to a psychotropic agent. So I'd recommend that you at least give it a try or consider giving it a try. There are concomitant benefits with doing CBT and also for depression or anxiety. Not only are you doing the CBT, if you're combining CBT with pharmacology, not only are you doing the CBT targeting the patient's symptoms, but you can also use CBT techniques to address the patient's predispositions, their cognitions with regard to the medication and its effect and the meaning of it for them. So, comparative efficacy, and this is a number of studies show that CBT, now, by the way, I think I make this point later, but all of the evidence-based psychotherapies tend to work equivalently in the research. So if you use interpersonal therapy, you'll use, what do we use for borderline personality? Dialectic behavioral therapy or MDT, any of those therapies, they're pretty interchangeable in terms of the efficacy with which they bring change. So we'll just say CBT here is kind of it's a stand-in for all of them. CBT's response rate, 66%. SSRI's response rate, 67%. Combined, 72%. So, 67% to 72%, or 66 to 72, at most is a 6% difference. So what is the number needed to treat? How many patients do you have to combine in order for one of them to do better? Well, you can calculate the number needed to treat on that to see that the number's relatively high, that you have to combine both fairly often for one person to do better than they would have on either alone. Okay, this slide shows, I think I have a reference here, I said no somewhere. This is efficacy of treatment types, and down the left side is the disorder and the treatment model, and then the standard of proof, what kind of studies demonstrate the efficacy. And you can click on that arrow when you project this at home, and you can go to Amazon and get that reference. So I'm not suggesting you buy it necessarily, but you can certainly consider it. There's a review article, 2005, with regard to psychotherapy of treatment-resistant depression. Highest quality study. Okay. Found CBT correlates with significant improvement in either the Hamilton rating scale of depression or the Beck depression in Newport. Are you seeing the whole slide up there? Is there a reason why that whole slide's not appearing? Did I do something wrong?
No.
There we go. Thank you.
She's a graduate student.
Yeah, okay. Yeah, it does look.
Yeah. She's rehiring her as a graduate, and so she was.
Okay.
Yes, it is.
Okay. Evidence for medication compared to CBT for severely depressed patients. This study. Evidence base for cognitive behavioral therapy in the acute phase of depression. Multiple studies, the efficacy similar to pharmacotherapy as monotherapy. Efficacy of CBT in combination with pharmacotherapy greater than either CBT or medication alone. And this is a systematic review there that you can click on. Evidence for CBT in the maintenance phase. There are multiple studies. CBT is greater in maintenance than medication. And the efficacy of CBT in combination with pharmacotherapy is greater than either CBT or RX. And then this is an earlier review. Depression-focused therapies typically produce response rates comparable to those found with antidepressant medication and randomized control. There's no compelling evidence that one depression-focused psychotherapy is superior to another. Addition of cognitive therapy or interpersonal therapy to pharmacotherapy increases the likelihood of remission for patients with chronic, severe, recurrent, or resistant. So there is some debate, but the general principle is both work. Combination works slightly better than either alone. And I don't have this represented here, but I do later. Pharmacotherapy tends to work quicker. CBT and psychotherapy tends to last longer. The effects last longer. And discontinuation of pharmacotherapy, it has about a 50% relapse rate on depression and anxiety disorders. And discontinuation of CBT and other behavioral therapies has a much lower relapse rate. So you get a long-term effect, beneficial effect, from doing the non-biological interventions. So what are the counter-indications? Well, cognitive impairments and cognitive therapy predict negative outcome of both medication and CBT. And patient preference is a negative indicator as well as financial. Brain image evidence. Brain image evidence discriminates which patients will respond to CBT. When exposed to a negative stimulus, depressed people who responded to CBT have decreased activity in the subgenual cingulate cortex and increased activity in the amygdala. So these are the depressed people who are responding to CBT. So they have an anxious depression. The amygdala is active in processing negative emotions. It doesn't turn off in some depressed patients. The subgenual cingulate cortex acts as a switch for the amygdala. And hyperarousal of the amygdala is correlated with rumination. And CBT is effective in cutting into that rumination. Evidence base for psychotherapy, treatment-resistant depression. The review article here, they say few random controlled studies. Okay, I think we did this one. Okay, we did that one. I think I have repeated some slides here. Okay, this is Morgan and Salmons reviewing what they're saying. And they are including, in 2001, the state of the field. There might well still be some information from Morgan and Salmons in the PEP because of their affiliation with the APA. And the medications included and psychological intervention. For OCD, combinations may be the treatment of choice for some. The studies failed to show a consistent advantage of combining treatment. Social phobia. Medication and psychological treatments are approximately equal. The medications, the MAOIs are the best. SSRIs are good. Relapse rates high on discontinuation. With regard to psychosocial treatments, they are comparable in effectiveness to medication. superior to medication in the change of phobic avoidance, and combined treatments. There are few studies at that time, but the studies that were there show good efficacy. And, however, it's not necessarily superior to singular treatment. By the way, why would an MAOI be the most effective treatment for social phobia? Somebody guess. If you guess wrong, you'll remember best.
I remember you saying that in our first class. I'm just trying to think about it.
Okay. Somebody make a guess. Why would an MAOI be the best treatment for social phobia? Any guesses?
Well, I mean, I'm trying
What
to
are
think
our
through.
choices?
Go ahead.
Our choices.
Oh, yeah, she wants four multiple choices. But I was just trying to think about through the action of the MAOI, it's just promotion of the presence of all the neurotransmitters because it's slowing the breakdown of those transmitters. I'm trying to think about why that would be specifically helpful for social phobia.
Makes it its most effective antidepressant. So the simplest answer is, well, it's the most effective antidepressant. And you treat anxiety disorders with antidepressants. Okay, specific phobias. CBT is the treatment of choice. It's equal or better in efficacy than medication. Combined treatments are not clearly beneficial. Why would CBT, rather than pharmacology, be the treatment of choice for social phobias? But why would it? Tell me more. Why?
With CBT, you're actually doing the exposure versus medication, which is getting rid of your anxiety. You're not actually getting rid of the anxious feelings that you're having against.
About a particular thing. And with a specific phobia, you're not anxious all the time. You don't need to have your anxiety taken away in general. You need to
Extinction.
become desensitized to and extinguish your anxiety with regard to the phobic object. And the medication's not selective like that. It doesn't just turn on when you need it and turn off when you don't. And so just a kind of an irrational way, you can understand why it wouldn't be the best approach. Medication and psychological interventions produce changes in several sleep parameters. Medication, acute changes in the sleep pattern, benefits not maintained after discontinuation. Psychological treatment takes longer, lasts longer. Combined treatment, short-term equivalent to or slightly better than monotherapy. Long-term effects mixed. Unclear that adding medication to behavioral treatment enhances the outcome. That's still true, even though this was 2000. We pay a price if we use hypnotics of whatever kind. We pay a price for psychotropic agents with regard to sleep because all of them change sleep architecture. At the same time, people suffer and can have a major depressive episode precipitated or mania precipitated by sleep deprivation. So it's important to treat problems with sleep. At the same time, psychopharmacological agents are not a good way to proceed. They're not the high road. They're not the best way, but they're a stopgap measure when other techniques don't work. You're doing something that's suboptimal, but it may be in that particular situation the optimum course of action. That's why your treatment of patients is individualized. You don't establish a rule and just follow it no matter who walks through the door in terms of which medications you're going to use and what approach you're going to take. As reviewed previously, combined treatment slightly better than either medication or psychotherapy. This is according to Morganson. Combined treatment is a treatment of choice. A less aggressive single treatment mode alone is likely to be effective in less severe depression. And psychotherapy has a lower relapse rate after discontinuation. And there's a lower negative impact of psychotherapy as a monotherapy. So that makes it the monotherapy choice. For this reason, we always recommend a trial of psychotherapy in a depressed patient before we lead to starting an antidepressant. Problem? The person may not be able to afford it. There may not be a provider available.
And have transportation.
Smoking cessation, nicotine replacement, and behavioral therapies in combination is logical and works, and the research continues to show that there is efficacy of nicotine replacement and tapering over and above straight CBT approaches and straight psychotherapeutic approaches to smoking cessation. People do better with nicotine replacement and slow titration than they do cold turkey. And they do better with Zyban, which is what? Which is what?
Bupropion.
Bupropion. Yeah, bupropion. That's right. And what else? What else do we give people to stop smoking? Chantix? Okay, and what worries us about Chantix?
Sometimes it's more anxious and they have nightmares and doing.
Yeah, and suicidal ideation, they get edgy, and yeah, it's not that big a deal. But there has been a report of increased suicidal ideation, edginess, and anxiety. So you've got to be careful and warn the person. You know, you're going to start taking this. Some people don't feel good when they take it, and they get strange thoughts and suicidal thoughts and everything. So if that happens, call me and stop taking the stuff. It's the medication if that starts happening, and you'll just stop once you stop taking the medication. So you immunize the person against the side effects. Okay. For smoking cessation, assess for stages of change, degree of motivation, degree of nicotine dependence, comorbid mental disorders. All smokers should receive nicotine replacement. Some medication should be considered. All should have behavioral therapy. Substance abuse treatment, research indicates medication does enhance recovery. Adherence is low without behavioral therapy. Behavioral therapy and medication in combination is the best treatment choice. This is Dowd and Januzak. With regard to depression, they're saying mild to moderate symptoms, psychotherapy alone, moderate to severe, psychopharmacology alone, and a partial response combined treatment. Now this is a psychiatrist, so you see his bias. Yes?
But this slide specifically is referring to just depression.
Yes. With borderline personality, DBT or MBT, insufficient response, add an SSRI, severe symptoms with aggression, add a mood stabilizer, with psychotic symptoms, add a second-generation antipsychotic. Major depression for Dowd and Januzak, pharmacotherapy, device-based therapy, and psychotherapy. OCD, mild, psychotherapy, CBT with exposure and response prevention, moderate to severe, an SSRI may combine with psychotherapy. Remember, again, this is a psychiatrist.
Do you have any protocols for which SSRIs you try first with different disorders?
It's a class effect, it doesn't matter. There are slight differences, so you know, for instance, in Paxil, and the differences, and we'll do this when we get to the pharmacology, so we'll talk about that. I'll talk to you about what are the bases on which you decide. The first thing you always need to think about is half-life. It's a class effect. An SSRI, all the SSRIs do the SSRI thing, but they have different half-lives. So some hang around a long time and some wear off. If you're going to have an abstinence syndrome, you're going to face that with the short half-life. Then there are a few fine-tuned differences with regard to what other sites they hit. So Paxil is not only an SSRI, it's slightly anticholinergic. And so you look at those other sites to see what kind of minor side effect differences might there be. But the main effect is much more pronounced than the side effects. So you can essentially randomly pick an SSRI. But if you're going to begin to think about which one, think first about half-life, adherence, and adherence issues.
And who gives you the best pens? Just joking.
That is something you might consider. And that will be on the ethics part of the test. A PTSD, start prolonged exposure, cognitive processing, stress inoculation, cognitive therapy. May add a benzodiazepine or other sedative hypnotic. This is a psychiatrist saying, yeah, you can give somebody who's got PTSD benzos. With persistent hyperarousal, add a beta blocker. Well, I would prefer the beta blocker and not the benzo, frankly. And also probably an SSRI rather than a benzo and a beta blocker. Insomnia, transient CBT and sleep hygiene, persistent CBT and a sedative hypnotic.
But this is the answers that they're going to want on the PEP, right? The PEP is going to ask us, and we should say benzo.
Not necessarily.
No.
I'm telling you, I'm giving you the range of what's out there in the research.
Okay.
You have to decide, when you look at that question, what you think the best answer is, and it's a judgment call. There is.
The one that's
You want to know what's the right answer. Sorry.
That's why we're here. We're here to pass the PEP.
No, you're here to review the variability in the recommendations and to make your seasoned clinical guess based on your own best judgment and face the reality that there is no right answer to anything in this world, and everything we now think will be wrong in 25 years. It's actually quicker than that.
Because it's
It's actually quicker than that. There's scientific revolutions. Everything we've thought scientifically in the past has been found to be wrong. So this is temporary knowledge, okay? Dowden-Januzek, we did that one already. Generalized anxiety disorder, acute mild CBT, acute moderate CBT plus a benzo or pregabalin. What is pregabalin? Lyrica. Chronic anxiety without prior benzo, CBT, SSRI, SNRI plus buspirone. Chronic anxiety with prior benzo exposure, CBT plus buspirone or an antidepressant and a benzodiazepine. That's how, there are a lot of people on chronic benzodiazepines. I must confess, I have a couple patients on benzodiazepines. Don't tell anybody. Bipolar disorder and schizophrenia, too complicated to include the slide. You can get their text. It's not a big text. See what they recommend there. The psychodynamics of prescribing. Transference, expectations, and can affect experience of other doctors, experience of other parental or authority figures, and interpersonal expectations. And counter-transferential reactions, both positive and negative, based on their diagnostic category, dependency, and other interpersonal expectancies. So your decision about who to medicate versus who to provide psychotherapy to, you have to remember there's counter-transference going on, and you need to be very clear in your own understanding of yourself about what kind of attributions you may be making about a patient and a patient's capability of managing a particular treatment plan. Knowledge of timing and sequencing of interventions to achieve maximum treatment effectiveness, including the importance of patient instruction. Well, there's little known about the efficacy of the timing and sequencing of treatments with regard to their method of action. Logic precludes attempting treatment requiring complex cognitive and emotional processing. That's what psychotherapy is. With a person who's cognitively impaired, for instance, severely depressed. Though Some people do it. The startup is extremely slow. Logic precludes utilizing a treatment modality that would require a major change in self-definition. You have a mental disorder that would benefit from medication. In a person whose sense of self is vulnerable, I feel deficient and incompetent, and would feel even worse about myself if I'm somebody who needs medication because I'm mentally ill, if patient adherence is required. So you have to be what you are, which is a skilled clinician in assessing what's appropriate for this patient. How do I manage working with this patient toward something that's going to work for the patient? Wait to start psychotherapy or medication until the patient's ready. Knowledge of practitioner-patient relationship and its impact on medication adherence, efficacy, adverse effects, response to side effects. We've done all this, talked about this more. Certainly offering psychotherapy or pharmacotherapy impacts your relationship. We call it a patient-centered doctor-patient relationship, or client-centered. The medical people call it patient-centered. It's the same thing. The medical people are about trying to do patient-centered therapeutic interventions, just like we do client-centered therapeutic interventions. Knowledge of the development and implementation of a coherent and organized plan of psychological and pharmacological intervention. You've done this for years. You've done treatment planning for years. You know how to do this. Diagnose, identify specific treatment targets, come up with a strategy for addressing each target, plan for assessing progress and outcome, and then institute the plan and reevaluate.
Can you give me an example of what a question would look like for that?
No. You give me one.
That's why I was like struggling. Like, what's it going to say? Like, should you gauge if your patient's improving? Yes, no, maybe, none of the above.
Or kind of like, what's the most effective way of determining somebody's getting better from medication?
From what?
Like from medication.
From medication.
Like, how would you assess that? I mean, we assess it in psychotherapy. We give them effective measures. How are you doing with your depression?
Yeah.
So it's the same thing with medication. We kind of do the same thing.
Yeah.
Any other thoughts? The question is, what would be a good question over this? Knowledge of.
I mean, it just seems like a falling off the log kind of question. Like, it's hard for me to think, like, how would it be, like, hard, I mean, what knowledge could I get to feel more robustly knowing this or something? Like, it just feels like, yes, we take measurements, yes, we determine if people are getting better or not. That just, it seems apparent.
Remember, they're clinical vignettes.
Okay.
So they're likely to give you a John, a patient who's 34 years old, presents with symptoms of anxiety and depression, and you have evaluated his psychological state and have selected a particular treatment target. Among these things, what other considerations would be most important, or what would be the most important consideration to include in your decision about what treatment to recommend? And then it gives you 4 alternatives. And one of them includes more information, the most relevant information that you need to consider in deciding on which psychotropic agent. So that would be, that's the level of question where they're going to say, okay, you know all of these things basically are important. Well, demonstrate that by picking which of these, in this case, which of these things is it most, you need to make sure you do in deciding what agent you're going to.
I think I saw a question by Muse, I think it was Muse, that says, number one reason why patients fail medication. And I think the response was non-compliant.
Then that gets at this.
I think so, because it looks like it's talking about treatment plan
Follow up about how they're taking their meds and things like that.
and pharmacological intervention. I guess sticking to the treatment plan, doing the intervention.
Knowledge of case and medication management techniques to enhance adherence. Communication skills, patient education techniques, cultural competence. Okay. This chart, it shows the relationship between poor medication adherence, poor health outcomes, increased service utilization, increased healthcare costs, and costs passed on to the patient. So this is a conceptual diagram showing that some of the problems that are actually overloading the U.S. healthcare system. And so you might, it's possible to write an abstract question about something like that set of relationships. This is all of the factors that may affect medication adherence. With regard to adherence, non-adherence rates are 25 to 75%. Adherence means a willingness and an ability to carry out a treatment plan. Adherence is enhanced by an active and constructive alliance with the provider. It's enhanced when there's a clear rationale for why are you supposed to do this? You really have to get the patient to understand, have their intellect on board about why is it important to do this. And it's enhanced if they're involved in constructing the treatment plan. One person would like to enter the room. Okay. So what is the patient's desired treatment and feelings about the proposed treatment? Preferences taken into account, consents fully to the treatment plan, comprehends the plan, and remembers to follow the plan. Alternative recommendations explained, side effects of each treatment explained, instructions are given regarding what the patient is to do if the patient experiences side effects. Plans with fewer moving parts. I have to take chronic medications. I have to put them in those tubes that have the day of the week. So I'll remember, I'll be able to tell whether I took it today. And I are a PhD, and I still need reminders to take very simple chronic medication. Multiple doses within a day in someone who is cognitively impaired is unrealistic at best. You've got to really consider what is it possible for this person to do in coming up with a treatment plan. And certainly duplicate instructions in written form, not just on the pill bottle, but write it out for the patient. Knowledge of pharmacoeconomics, cost issues, cost affects adherence. By the way, one of the things that we've just recently, there's been a nice study that shows that if you give a patient a 90-day supply, they're more likely to adhere. Having to go back monthly to get a refill has a negative impact on adherence. And if you expect it to be a chronic medication, you're much more likely to contribute to the health of the patient if you give them a 90-day supply with 2 refills. And you can always stop the medication if you decide it needs to be stopped, but having that automatic refill with longer supplies means that it's more likely the person's going to take it. If they need it, you better not prescribe it unless you think they need it. And if they need it, then it'd be best if they took it. and you better do what you can to see to it that they're able to take it. Impact of, okay, here's a nice review article on Medscape, impact of pharmacoeconomics, patient adherence and outcomes, and the NCBI, there's an article there that you can click on. Okay, now I'm stuck on this slide. Oh, what have I done? Am I done?
Yeah, just like this.
That's the last slide. Ha ha! Hallelujah. We're going to keep going to noon, and then we'll take a break at noon.
Now, when it comes to medication adherence, or even treatment plan, it could be even psychotherapy, working on the Navajo reservation, we're supposed to be the experts, but a lot of times they have family members who are more of an expert. So they may say, well, you went to 2 psychotherapy sessions. Are you done by now? Or even with the medication, you don't need to take that. You just need a ceremony.
Mm-hmm. Now this is where your skills as a psychologist come into play, and knowing who the decision makers are. And you're not going to get adherence unless you persuade the decision maker that adherence is an important thing. So who do you include in the session? We have at the Family Medicine Center, it's family medicine. We have families coming in. And we have a number of Latino families who they present as a family group, and there's a family decision maker who may be mom, maybe, who's there with the patient, and mom has to consent to patient's treatment plan, even though it's a middle-aged adult woman, her mother's there, and so it's really working out a treatment plan that is acceptable to the family. So there's not intra-family sabotage of the treatment plan. So your skill as a clinician comes into play in figuring out who do I need to have involved in this process of decision making in order to have the treatment plan be realistic. I mean, we feel good about our treatment plans. That's not enough, It may look good on paper, but it's complete bull unless it really matches the patient's treatment plan and the patient's system's treatment plan. And combining, if there's any way to combine psychopharmacological agents and administration with a native ritual. I mean, if you live in the community long enough and can develop alliance with community leaders enough, there's a way to build bridges that way. That's essential in order to practice anyway, to be able to make a difference. But that's all cultural competency. Neuroscience, 8% of the PEP, refers to the anatomy, physiology, and biochemistry of the nervous system and its interfaces with other major body systems. Structure and function of nervous system cells. So you can click on that link and have a look at a cell. You need to know the parts of the cell, the dendrite, cell body, nodes of gravity, nucleus, axons, myelin, presynaptic terminals, and terminal boutons. We're not going to be covering the structure and metabolism of cells in general, but focusing on the neuron in particular, as it's a specialized cell of most interest to us in our study. Tree-like form, surrounded by a membrane, composed of a bilipid layer. So what does that mean? What is the fact that it's got a bilipid layer? Why does that matter?
Because some medications are fat soluble or water soluble.
So what difference does it make if it's water soluble?
It'll tend to have more difficulty getting into the cell, right?
That's right. So the bilipid layer is lipophilic and phobic of water, hydrophobic. So that bilipid layer we're dealing with in transporting water-soluble electrolytes across that membrane is a project. And that's why there's all this hoo-ha that you read about how neurons fire and the transport of those electrolytes in and out of the cell membrane is because that membrane is in fact impermeable unless there are methods of transport across that membrane, unless there are little holes in it. Okay, so all of what you know about how this thing works is caught up in remembering that that bilipid layer repels anything that is hydrophilic. It dissolves easily in water, and sodium, potassium, and calcium ions are hydrophilic. They dissolve in water. Functions more like a thin layer of oil floating on the surface of a swimming pool, with inner tubes composed of protein floating on the top of it. And in the middle of the inner tube, there's no oil, so your electrolytes can dive through those holes.
That's a really good image.
All neurons and all living cells are electrically polarized with a slight negative charge inside relative to the outside, the interstitial fluid. And think the inside and outsides are water, and so the electrolytes are dissolved in the water and the interstitial fluid are inside the cell. The neuron has voltage-gated channels. What does that mean, voltage-gated?
It means it depends on the charge.
The gate opens up when you apply a voltage. It's voltage-gated. So the hole opens up when you apply a voltage. Voltage-gated channels for potassium. That's a positive potassium ion. And sodium, positive sodium ion. The neuron also has active transporters or pumps that will transport substances through the bilipid layer. So the way you get something across that is hydrophilic is either a hole has to open up for it, or something has to transport it across. Use energy to transport it. As the ionized form of these elements are lipophobic, the only way they pass through the bilipid layer of the cell is when the gate is open. Some drugs can also affect the channel's propensity or resistance to opening. Give me an example of a drug that can affect the channel's propensity or resistance to opening. What of your psychotropic agents has, as part of its method of action, affecting those channels' propensity to open? No. Yeah. That wasn't the one I was going for. That wasn't what I'm going. I'm going for, it's how the method of action of lithium. So let me give you a clue. Lithium, one of the reasons that lithium is presumed to work is that it reduces the propensity of those ions to pass through the cell. And so it kind of stabilizes neural transmission along neurons. The voltage potential between the inside, which is negative, and the outside, positive, of the neuron is maintained at an equilibrium because the membrane is semi-permeable, and it's maintained at minus 70 millivolts. If the membrane was impermeable, there would be no potential. And if the membrane was permeable, there would also be no potential. Why is that? Why is it that if the membrane was permeable, completely permeable, why would there be no potential?
Because it would always be equalized with a surface.
Yeah, the charges would be equal. They just swim across and they equally distribute on both sides due to the diffusion force. So they would diffuse across to both sides So the water in the inside and the outside would have the equal amounts of those electrolytes in them. And the sodium and the chloride would glom back together. And the potassium and the chloride would glom back together. And so then you'd have sodium chloride and potassium chloride. You have salt, the two kinds of salts, equally distributed on both sides, with some of the free neurons that hadn't quite glommed onto each other yet. Also in the interstitial fluids inside. Okay? The potential is maintained by an equilibrium, which is caused by the force created by differences in the concentration of ions being counterbalanced by the force created by the difference between the electrical charge on the inside and the outside of the membrane. There are two forces that cause this equilibrium. The first of them is the diffusion force, and it's counterbalanced by the attractive force caused by the electrical charge differences inside. In normal language, that wasn't normal language. This is normal language. Trust me. No, don't trust me. I think it's normal. You be the judge of it. If there's more of an ion on one side of a semi-permeable membrane than the other, then there is a voltage or a difference in charge between the two sides of the membrane. Remember, on your battery, the reason there is a voltage difference, the reason your battery has a voltage is that there are charges, negative charges, that are sitting there potentially ready to pass from the ground to the positive terminal. And it's because of the difference in the imbalance in those electrical charges that there is a voltage difference in your battery. This is just a battery, basically, because it's got more of one charge on one side than on the other. The only way for there to be more of an ion on one side than the other is for the membrane to be semi-permeable. If it was completely impermeable, then there wouldn't be any connection between the two. It has to be semi-permeable, so there can be more of one ion on one side than the other, more positive charged ions on one side. Nernst equation can be used to calculate the voltage difference for a single ion system. An ion pump will use energy to transport ions from one side of the membrane to the other. The longer the pump works, the greater the concentration of the ion shifts from one side to the other, the greater the voltage. So remember, we have two ways for these ions to get through that bilipid membrane. One way is for a voltage-gated channel to open up, and so they can rush through. And the other way is for these transporter systems to grab them on one side, lock them down. And what's happening as a neuron fires is, when it fires, they rush through and try to equalize. And then when it's done firing, the firing causes that voltage that opens the voltage-gated ion channels. Those ions rush through, then they slam closed when the voltage has gone by, and then those transporter systems work to pull those ions back out to redistribute them to the resting potential of minus 770 millivolts, with the inside more negative. The longer the pump works, the greater the concentration.
Is the Nernst equation important? I don't remember that.
Know that there's such a thing as a Nernst equation. Do not be expected to calculate it on the PEP exam. Know that it's related to the concept of neural firing. and the maintenance of the resting potential. So it's that level at which you need to know about the nerve. If a gate appears in the membrane and the gate opens briefly, then ions rush through, and that reduces the voltage difference between the inside and the outside. When the gate closes, the pumps work to transport the ions back so that an imbalance can be created, which results in that classic voltage difference. This process of pumping ions maintains the voltage potential. Now consider a substance like potassium chloride. When in its ionic form, potassium is positive and chloride is negatively charged. And these ions are held together by their respective charges, creating potassium chloride, which is neither positively or negatively charged. Suppose the membrane is semi-permeable, letting only potassium ions through. Some of the potassium chloride would dissociate, and the potassium ions would pass through the membrane and leave the chloride ions they were paired with behind. The side where the potassium ions begin to accumulate becomes positive relative to the other side because the chloride ions are stuck on that other side. So you got potassium chloride dissociating. The potassium, it's a semi-permeable membrane and it's semi-permeable to potassium but impermeable to chloride. And so some of the potassium swims across because as the potassium chloride dissociates, the free potassium ions are going to try to distribute themselves equally on both sides of the membrane. Why would the potassium ions leave to go to the other side? It's because of that diffusion pressure or diffusion force. But if you've got a bunch of free potassium ions and that membrane is permeable to potassium ions, they're going to try to distribute themselves equally.
When you say the diffusion, is that similar to the osmosis?
It's what happens with osmosis.
Yeah.
That's essentially what it's. Yeah, it's a similar principle. Yeah, it's a similar principle. Since any ion or chemical tends to distribute itself equally throughout a fluid. But in this case, the potassium chloride can't distribute itself equally because the potassium ions can go through the semi-permeable. They can go through, but the chloride ions can't. Since the potassium channel permits the free flow of potassium through the gates, it can begin to distribute itself equally on both sides. Not all the potassium is paired with the chloride. And remember, when you have that molecule dissociating, that's actually the same thing that happens in the GI system with your drugs as they travel down the GI system. They dissociate into transportable ions that can go, or forms, chemicals, molecules that can be transported through the GI tract. So the unpaired potassium will try to distribute itself equally on both sides while the chloride's stuck. As more potassium travels, more potassium chloride dissociates, and the diffusion force causes potassium dissociated ions to distribute themselves evenly throughout the liquid, except the stuck chloride ions are negatively charged, and that attracts the positively charged potassium. Yes?
Casey has a question. What is the force that is dissociating the sodium chloride?
That is a monovalent bond, and chemicals that have monovalent bonds when they are dissolved in water dissociate. I don't know what you call that beyond that, but that's just what they do. Okay? So, and that's what dissolving a chemical actually, I think, means, but I don't know what that means. Okay, the stuck chloride ion's negative charge creates an attractive force. The electrical force keeps the potassium ions from accumulating on the other side. Remember, they're trying, the ones that get freed up over here, they're trying to equally distribute themselves, but now the trapped ions, positive ions, are going back on it. And so you have the positive potassium, there's an attractive force. At the same time, there's this repelling force, which is the diffusion force. You have the electrical attraction force. So these forces counterbalance each other. When that happens, considering the gas constant and the absolute temperature, as well as the voltage and Faraday's constant, as calculated by the Nernst equation, we have an equilibrium created. So we don't have all of the potassium chloride dissociating with all of the potassium leaving. In the typical neuron, there are 3 ions that are important: potassium chloride and sodium. Other ions also present. Additionally, protein chains. So it's not, the charge of the inside versus the outside is not just due to potassium chloride. So that's the biggest story, and that's the main reason for that charge. You add on sodium chloride, dissociating with sodium being positive. And protein chains may be charged, and there can be big proteins with a charge stuck inside the neuron because of their size that hold a negative charge. And the permeability and concentration of each ion summed creates the equilibrium potential, which is that minus 70 millivolts. In the typical neuron, potassium ions are driven out by the concentration gradient, and ions attached to the large proteins remain inside and make the interior negative. Chloride flow is blocked due to the membrane, which is almost impermeable. The membrane potential is created by potassium ions close to the Nernst potential, plus the sodium selected channels have a high resistance to the flow of sodium. Therefore, little positive sodium passes, so that the diffusion gradient has little effect on the membrane potential. So the ratio of sodium to potassium going across is 1 sodium for 100 potassium. So remember that membrane potential is primarily a potassium story. Sodium makes the membrane potential slightly more positive than could be attributed to the potassium alone. So that's why the outside's a little more positive than the inside by minus, the inside is minus 70 millivolts relative to the outside. Sodium and potassium imbalance causes the fasciculations in ALS. Fasciculations are a characteristic feature of ALS. They arise proximally or distally in the motor neuron, and it indicates a widespread disturbance in membrane excitement. Well, here's where, even though you may think this is only about firing neurons, and we only are interested because we're looking at neurotransmission and changing neurotransmission rates with our psychopharmacological agents, well, in fact, a symptom is caused by the degradation of a neuron and that balance in sodium and potassium. hyponatremia. Now, think about hyponatremia. We just noticed that sodium is involved in neurotransmission by virtue of the maintenance of the balance between the inside, the charges on the inside and the outside of that neuron, and how easily it is brought to an action potential and transmits that action potential down the axon. So hyponatremia is directly impacts that balance, and some of your medications can cause hyponatremia. Okay? You can look at MedCram videos. I think you'll find that interesting. You'll find the MedCram videos interesting. All the psychopharmacological stuff on MedCram videos. Now, on YouTube, there are lectures on anything you want to know about psychopharmacology. There's a nice, quick, simple lecture on it on YouTube. I did that already. The neuron can respond in one of two ways to stimulation. Local currents can be generated which tend to dissipate over a distance and over time. These are leakage currents which alter membrane potential slightly and are of not much interest. Action potentials propagate along the entire length of the neuron and may be assisted by saltatory conduction, which is the jumping of the action potential from one node of Ranvier to the next along the myelin sheathing that covers the outside of the neuron. Where do you see myelin sheathing?
Around the axons.
Around axons. And that's, when you look at the brain and do brain slicing, that's white matter. You're seeing transmission lines, transected transmission lines. And so you cross-cut transmission lines in the brain, and you're seeing the myelin sheathing, and that's the white matter. The gray matter are areas of synapse. Okay. Behavior of the neuron requires voltage-gated channels. A critical level of stimulation causes a threshold to be reached, and the action potential you can see in a little cartoon thing of it firing. Click on that. Amuse yourself. You can watch that for 30 seconds. Neuron behavior. Action potentials and postsynaptic potentials are the two most important means of the transmission of information within the organism. But what's another means? The endocrine system, the lymphatic system, the endocrine system transmits information slower. But the fast stuff is these action potentials and postsynaptic potentials. The fastest stuff is direct contact transmission, like in spinal reflexes, where it's electrical. It's not a synapsing with a chemical transmission to the next neuron, but it's actually two neurons touching, and the electrical signal from one destabilizes the next neuron. Was that dinging a sign that it was 12 o'clock? Somebody's 12 o'clock
You got 3 minutes.
Somebody's stomach alarm? Did I hear a bell, or have I lost it finally? What do you mean finally?
Someone's phoning.
Yeah.
The postsynaptic potentials are the potentials of most interest to psychopharmacology, as those are most affected by drugs. But as I just pointed out, but there are some exceptions to that. It's not just postsynaptic potentials, but we are messing with that membrane with some of our psychopharmacological agents, if the side effects as well as a therapeutic effect of some of the mood stabilizers. Neurons. Some transmission of signals from one neuron to the next happens due not to chemical stimulation, but electrical. Action potential of one triggers action potential to another, which is physically touching. This is useful when the speed of conduction is important, and that's really spinal reflexes. And you know that you stand upright by virtue of rapidly synapsing electrical connections in your spine that adjust the tension of your oppositional skeletal muscles. And without knowing, it's a miracle that you can stand up and you couldn't make yourself do it consciously, because it requires those micro contractions and relaxations of opposing muscle systems synapsing in your spine that allow you to stand erect and keep just the right amount of attention in your legs. Remember, signals pass primarily in three ways: fast, electrical stimulation, one neuron to the next; slower but still fast, chemical neurotransmission; and then hormonal is slower, using the blood and lymphatic system as local, like paracrine. As psychopharmacologists, we're influencing the second and third, either speeding up, reinforcing, mimicking, dulling, or blocking the sending of signals. It may be that the norepinephrine effect in descending signals in the spine that causes gating in pain transmission. I'm not sure whether that is, I don't think that's electrical. I think that is signal. Closing gates there. So it is, we're on slide 29 of 141, so we won't be able to finish before lunch. So we're going to take lunch. So back at 1?
Yes, and as I said earlier, because of the parking situation, it's
Ready to the terminal boutons so that the chemical messengers can be squirted out, swim across, and destabilize the next neuron. The action potential is what does that. And it's produced by ion movement. Sodium moves into the cell, and then potassium moves out. The inside of the cell is briefly highly positive relative to the outside. It takes time to reset the membrane's charge before another action potential can be propagated. That's the absolute refractory period. And remember, what's going on then is those pumps are operating to get the ions on the correct side to reestablish the action potential. Additional, more intense stimulation can propagate another action potential during the relative refractory period. So we have differential firing rates. And remember that it's not just the neuron firing, but neurons can fire at different rates, and more than one neuron can team up to stimulate a downstream neuron. So we have gradations in the speed with which signals are transmitted. Okay. Produce bone carrier, now I'm stuck again. Let me see if I can get this working. Here we go. You know, I discovered if I click on the slide, then I can, with this thing, if I touch that thing, I'm toast. If it's not on there. Okay. The action potential is propagated by voltage-gated ion channels that open up, allowing the ions to rush to the other side. Potential is restored by the sodium-potassium pump, which uses energy to move sodium back out and potassium back in, and by the diffusion gradient of the ions when the voltage-gated ion channels close. The sodium-potassium pump is powered by an ATPase metabolic engine, and it moves 3 sodium out for each 2 potassium in. The changes in permeability of sodium and potassium channels due to voltages are responsible for the movement of those ions during the action potential cycle. And during the absolute refractory period, the sodium channel is inactivated, and for that reason, That's why it can't possibly fire directly. Knowledge of the structure and function of the central and peripheral nervous system. The brain, spinal column, and peripheral nerves. When the axes, and knowing axes are important if you're reading neural images, because you need to know what kind of a slice of the human being or the brain are you seeing, and which side are you seeing up and down, right and left, and which is right and which is left, and which is up and which is down. One of the original stimulations to the marking of the physical body of lung transection patients was the accidental removal of the wrong and non-cancerous lung in a patient who had a lung cancer at the University of Texas. And from that point, any surgical procedure, there are repeated, actually marks placed on the body of the patient, diagrams pointing to the part that's supposed to be fixed. And there, the team comes in and verifies, have we got the right patient? Yes, we do. What are we, and now the protocol in hospitals is to have this talking, they have a talking script where they step through verification of the identification of the patient, verification of the procedure to be done, verification of the location of the procedure to be done, and then checking to make sure the body is marked at the spots that correspond with the transcript that says what's to happen to the patient because of accidental removal of the wrong lung, and then also at times replacing the wrong knee and those kinds of things. So that knowing the axes, knowing where things are, and being able to read those images and know what you're looking at, that's primarily why you need to know what those axes are and what they refer to. So there's vertical axis, which is parallel with the spinal cord, horizontal, parallel to the eye sockets. Dorsal is posterior, remember dorsal fin. Superior toward the skull, that's also the vertex. And ventral is anterior toward the front, or stomach, inferior toward the palate. Planes of the body, rostral is toward the head, caudal toward the tail, medial toward the midline and lateral, and distal toward the outside. The covering the brain, the dura mater, anacroid space, and pia mater. Think AD is the acronym. Pia mater, arachnoid space, and dura mater. And dura mater literally means what? Tough mother. It is and if you actually engage with some dura mater, you will discover, yeah, it's pretty, it's a kind of a...
Yeah, when we dissected the sheep's brain.
Oh, you did the sheep's brains, yeah.
It was tough stuff.
Yeah.
Tough mother.
Yeah, that's right. Okay. So a subarachnoid hemorrhage is where? Between what and what?
Pia and dura.
Between the pia and the dura. A subdural hemorrhage is where?
Between the
Dura and the arachnoid. So it's below the dura mater, above the arachnoid space. Okay. So what happens if you get a bleed, a subdural bleed?
Pressure on the brain.
Yeah, creates this pocket of blood, the pressure, and eventually the pressure of that pocket pushes back against the blood pressure enough that it doesn't necessarily get larger, but it's basically crushing the brain, displacing it possibly to the side, maybe pushing the brainstem down to the foramina magna, which can in fact cause respiratory arrest and death. And it's not good. The basic survival instinctual mechanisms are located in the brainstem, and if you occlude the brainstem, you compromise life. Okay? Inside the brain and the spinal column, the white matter, we talked about that before, and gray matter. And you saw that with your sheep dissection. How, everybody here dissected the sheep brain? You're all participating in that? Have anybody done human brains?
I've held one before, but I
Yeah.
haven't dissected it.
They're just like big sheep brain. Yeah. Well, the higher cortical areas are a little more, they're puffed up a little more relative to the sheep, but that's what we expect because that's what we're using now to apprehend this material. And elsewise, we would be sheep. I guess, kind of milling around in here and searching for something to graze on. Brain areas of special interest. The amygdala, the basal ganglia, the frontal cortex, the hippocampus, the hypothalamus, the limbic system, the locus coeruleus, the mesocortical region, the mesolimbic region, the nigrostriatal area, nucleus accumbens, nucleus basalis of minor, pituitary, raphe nucleus, striatum, and thalamus. So, watch those YouTubes. You'll enjoy them. The amygdala. Why do we care about the amygdala?
Fight, anxiety, fear.
Anxiety. And where is it located? Well, there's a picture of it, but relative to the limbic system, where is it?
Next to the hippocampus. And attached to the hippocampus.
I believe. I'm going to ask the neuropsychologist.
Put me on the spot again. He's doing it again.
Is the amygdala attached to the hippocampus?
Within the brain limbic region.
It's those horns that come in the limbic region. It's out there on the front of those, isn't it? On the large end?
Yes, the amygdala is like the eyes looking outward.
Okay. And here's the hypothalamus sitting above or below the thalamus. And see where the amygdala is relative to the limbic system. Dopamine centers in the nigrostriatal area. Norepinephrine centers down there lower in the brainstem. Basal ganglia. Frontal cortex. So the front, pardon me, in front of the central sulcus, right? And so, does the material in front of the central sulcus or behind the central sulcus drive motor behavior?
Behind.
Behind? Everybody agree? Well, then what's the point of the front?
Sensory.
Yeah. Is that right? Okay, here is the hippocampus. Behind the temporal lobe of the brain. Here's the hypothalamus. And what's that hanging down from the hypothalamus? That cherry thing? That cherry's the pituitary, right?
Encased in bone.
Encased in what?
Bone.
So if you want to operate on it, what are you going to do? Drill a hole in somebody's forehead? If you're going to operate on the pituitary, how do you approach that?
Through
The nose.
yeah.
So why is it there? Why is the thalamus above the hypothalamus and why is the hypothalamus above the pituitary?
They all relate to each other.
The access, right?
So that's right, it's regulation, and it's the chain of regulation, isn't it? So it is the releasing hormones from the hypothalamus stimulate the stimulating hormones, or is it, now let's go backwards.
Hypothalamus.
The hypothalamus does what to the pituitary? The hypothalamus sends releasing hormones to the pituitary, and the pituitary releases stimulating hormones to the body. Is that right?
Anterior.
I think so.
Okay, somebody Google stimulating hormones versus releasing hormones. You need to know this sucker.
First it gets stimulated.
So, what do you find when you Google that? Read out what Wikipedia says about hypothalamus, pituitary stimulating and releasing hormones. John Andazola says if all you do is listen to me, you won't remember anything. Who's prepared to read what you
Here it
have?
is. Releasing hormones and inhibiting hormones are hormones whose main purpose is to control the release of other hormones, either by stimulating or inhibiting their release. They are called liberians, right? And statins, respectively, or releasing factors and inhibiting factors.
But we want to know which is in the hypothalamus and which is in the pituitary.
Okay, so the
Releasing
hypothalamus,
the hypothalamus.
the hypothalamus uses thyrotropin releasing hormone to tell the pituitary to release more thyrotropin. Hypothalamus uses corticotropin releasing hormone to tell the pituitary to release more corticotropin. Hypothalamus uses gonadotropin releasing hormone to tell the, so it's lots of hypothalamus to pituitary.
The hypothalamus sends releasing hormones to the pituitary for all three of those systems. And then the pituitary does what? It sends stimulating hormones to the target organ.
In the body. Right.
So it sends thyroid stimulating hormones
She's
to
having
the
a problem
thyroid gland.
The language. Go ahead and say the rest.
Go ahead.
For here.
And
So the hypothalamus will release the hormones to anterior pituitary. And there's a difference between the anterior and posterior. Now that I'm on the hot seat, I'm not going to be able to explain those differences.
Well, you're going to Google it right now and you're going to tell us. The difference between the anterior and the posterior pituitary.
Now, so basically, the hypothalamus releases the releasing hormone, and then the pituitary releases the stimulating.
That's right. And so the stimulating hormone goes through the systemic circulation or through the lymphatic system to the end organ, and then the end organ releases the actual hormone. So the gonadotropic stimulating hormone goes from the thyroid to the gonads.
Now, does it go in both blood and lymphatics?
I think it does, but it's primarily blood-borne. So she's about to tell us the difference between the anterior and the posterior.
Yeah, so I'm totally on it. Totally. So the anterior pituitary, it has more hormones, which I could go through them. The posterior lobe is responsible for 2, all of which comes from the hypothalamus.
Which two?
What are the 2 things that it does?
For the posterior, it's the antidiuretic hormone and oxytocin.
And what does oxytocin do?
Bonding
It is
hormone.
involved in a variety of processes, such as contracting the uterus during childbirth and stimulating breast milk
Pitocin.
production.
That's the big one. That's oxytocin.
But it's like if you pet a dog, it releases oxytocin in the dog and in you.
It does. And in women, they get their testosterone by converting oxytocin to testosterone. I didn't know that.
When
And
you have a pituitary tumor, there's a lot of problems with that.
but now, why do we care about the other one besides oxytocin? What is the other one?
Antidiuretic?
Antidiuretic hormone.
So in brain injury, you can have the syndrome of inappropriate antidiuretic hormone. So it kind of regulates the water balance.
And what does an antidiuretic hormone do? It keeps you from diuresing. And what is diuresing?
Losing all your water.
Yeah, it's basically peeing. Yeah. So if you stimulate antidiuretic hormone, you are stimulating the blocking of diuresis. So you're going to cause hyponatremia and hypo everything else that's in the blood because you're bulking up on fluid relative to chemical in your blood. And so it's not just brain injury that causes the syndrome of inappropriate antidiuretic hormone, which is SIADH. But what else causes SIADH? A bunch of our medications. So now, who's got Hippocrates on their phone? Somebody look up risperidone. Somebody look up carbamazepine. Somebody else look up carbamazepine.
I'll get carbamazepine.
Look at the adverse effects of risperidone, carbamazepine, and let's say Abilify.
All right, so I got carbamazepine, then what did you want me to look up?
Look at the adverse effects and see if it says SIADH.
What does it stand
Yes,
Syndrome of inappropriate antidiuretic hormone.
hormone secretion, yes.
Carbamazepine, yes.
Carbamazepine, yes. Look for Abilify, look for risperidone.
Nicotine causes anxiety?
Whispered.
So we give a medication that induces SIADH to a woman who is 72 years old. And 3 days later, she comes into the clinic and she has been seeing aliens eating her vegetables in her garden. She's very upset and she's called the police and her daughter brings her in. What happened?
Delirious.
How did she become delirious?
Medication caused her to retain water, didn't have the required salt or synapses.
That would be wrong, but it's a good guess.
I was with you on that one.
The most obvious answer is you induced a urinary tract infection because what you did was inhibit her voiding. And urinary tract infections in older women are the #1 cause of delirium.
In 3 days?
Rapid onset delirium, absolutely.
That's delirium.
No. But I mean, the infection would set in 3 days to the point to set in delirium.
Those beasts don't, those little bugs don't take very long to propagate.
Plus, 70, geriatric. How do their kidneys function?
Okay, so now let's work our way back up to the hypothalamus. Remember, it sends stimulating hormones to the pituitary. To the posterior pituitary, there are 2 primary hormones, the antidiuretic hormone and oxytocin. The anterior pituitary is thyroid stimulating hormone. Yes. Thyroid, it's basically the thyroid stimulating hormone that's released there, as well as what? It's the other system. It is the arousal system. It is the catecholamine system. What is that system?
Parasympathetic? Is that what you're getting at?
No, it's sympathetic. Yeah, I guess it's innervated by the parasympathetic branch also, but it is, what is it that happens at the level of our kidney and the gland on the top of our kidney?
Adrenal?
Yeah. So what is that system? A hypothalamic, cortical, what is it? Hypothalamic, cortical, what is that system?
HPA is what Casey said.
That is correct. Casey called it. Is he, oh man, he's good.
We're driving them crazy online.
Really?
They're giving the right answers and we're not.
And we're not paying attention to them? Those poor people. They should be here so they can suffer like the rest of you. They're home there, lounging. You know, I can see it, probably got a glass of wine on the table, you know, looking stuff up, you know.
Dunking on us.
Watching a little baseball, you know, tuning in and out.
To the face play.
Thank you, you're right. Okay, so remember those axes, the story of hormonal control, which we'll get to later, is those negative feedback loops that involve sensors at the level of the thalamus and the hypothalamus that then decide whether to send stimulating hormones to the pituitary to send, releasing hormones to the pituitary to send, to do that because that confuses you. Confuses me. The hypothalamus send releasing hormones to the pituitary, so the pituitary sends stimulating hormones to the end organs, so the end organs produce the hormones, and then they circulate and the brain says, okay, we got enough of that, and so it turns it off. Okay? Now back to the brain. The hippocampus and the fornix, the limbic system. Why do we care about the limbic system? Your sheep had a limbic system, didn't it? And it had a limbic system pretty much as good as ours, didn't it? Yeah. Yeah, mammals have limbic systems. They got emotions. Okay, the locus coeruleus. What? Let's ask our neuropsychologist what the locus coeruleus does. She's going to Google that real fast and she'll tell us. Somebody Google,
Oh, well, let's resolve.
what does the locus coeruleus do?
Does it produce some of the neurotransmitters?
Physiological response to stress and panic.
I just don't want to say the wrong one because they don't have patent response.
Okay. What does the nucleus accumbens do?
Pleasure, reward.
Yeah. Dopamine.
That's, man, you know that one.
Wow.
Yeah.
I've had it
Is there any reason why you know about the dopamine reward system and don't know about the...
Well, we deal with a lot of addiction.
Yeah. I have had more interest in that system myself. Okay. Nucleus basalis of Minor. What the heck does it do?
Is that in the prefrontal cortex? Or is that in the limbic
Yes.
system?
It's
Oh,
connected to the
neocortex.
limbic system, but it is lighting up the neocortex. So it is turning it on and projects to the thalamus. So somebody look up, what does the nucleus basalis of Minor do?
I know that when it's stroked out, it can cause abulia.
Okay,
I know that.
so that's cool. And so what is abulia?
Abulia is,
A disconnection between,
it's a lack of will, lack of motivation. You can have amotivation, abulia, sometimes.
the person can know sort of at a higher cognitive level something needs to be done, but they can't motivate themselves to do it. They don't motivate themselves to act, right?
Is that different from abolition?
Well, avolition sound, sort of similar, yeah, but that's sort of the medical name for an avolitional syndrome. So what does Google say about the nucleus basalis of Minor? See what these guys, oh, he's still saying play alive.
Vision?
Vision? Could be. Did he Google that? He's pretty good.
That's what Wikipedia is saying, talking about vision.
But it's connected with a bunch of other stuff.
It is. And it's about reality versus virtual reality, something like that in there too. It's weird.
So maybe it has something to do with psychosis.
That's what I was thinking.
What do you think? Neocortex making sense of...
I think it depends on the pathway, because the memory loss associated in Alzheimer's sometimes linked to that nucleus. So it depends on the pathway and cortical.
Well, notice the thalamus, all the sensory inputs go through the thalamus. And so this is connecting the thalamus to the neocortical areas, which interpret, make sense of reality. So we'll find out later. Pituitary, we've talked about the raphe nucleus. Why do we care about the raphe nucleus?
Isn't that where some of the neurotransmitters are?
We've got a bunch of neurotransmitters, and we affect them there, but what good is one of these?
Does it produce it or just project it?
The neurons, any part of the central nervous system or peripheral nervous system that has neurons that use neurotransmitters, those neurons produce those neurotransmitters. So, they're generated by those neurons. If a neurotransmitter swims from one place to another, that's a hormone, basically. So the local transmission, the neurotransmitters are built. So if there is, let's say, serotonin-rich neurons in the raphe system, then they produce serotonin. Now, what does the miracle of the internet tell us a raphe nucleus is good for?
The main function is to release serotonin.
Is to what?
Release serotonin.
Releasing serotonin.
Yes.
But it's got to be doing some, yeah, it does, but
Pain mediation.
pain mediation?
So it says the main function of the nucleus raphe magnus is mostly pain mediation. It sends projections to the dorsal horn of the spinal cord to directly inhibit pain.
And we see that arrow going down. Anything else? I think it does. We'll check back in on it. Striatum. What good is a striatum? Those are pretty deep, aren't they? If you look at where they're located. What's Google tell you a striatum's good for? Anybody?
Reward system.
What's it say?
Part of the reward.
Part of the reward system. Thalamus, we talked about it. Brain structures, the amygdala. You can look at the amygdala, the raphe. Okay, we'll go through these according to sort of a crude. The raphe, serotonin and sleep, pain control, and activity disorders. Amygdala, anxiety. Locus coeruleus, noradrenergic pathways. Frontal cortex, executive function. Limbic cortex, emotional valence. Hippocampus, memory. Hypothalamus, neuroendocrine and motivational regulation in the appetites. Pituitary, stress. Well, we know it does a bunch of other stuff too. The ventral tegmental area, dopamine and schizoaffective disorders. Mesencephalic tegmentum and myelencephalic tegmentum, norepinephrine cell groups, and attention. So what's involved in psychosis and schizophrenia? All of these. So it does look like we were right about the involvement in interpretation of reality. Septum, aggression. Okay, the cerebral spinal system, or cerebral spinal fluid. It circulates through the ventricles. It's produced by epithelial cells in the floor of the lateral ventricles and the roof of the third ventricle. When you did your sheep brain, did you see ventricles?
Yeah.
Okay, did you actually see any of the tissue that produces CSF in sheep? Or did you not? It's pretty hard to see. I mean, it's really,
Some people found stuff, other people were like,
it's kind of hard to find. Yeah. Flows down through the ventricles, passes through foramina, circulates around the spinal column, and there are 4 exits through the central canal for foramen of Magendie. Would you pronounce that for us, neuropsychologist? Magendie?
Magendie.
Yeah, that sounds right. That's close to
Foramina of Luschka. And the CSF flows into the cisterna magna. And what good is having CSF? I mean, why do we have it? It drains into the lymphatic system, right? So what does it drain out of the brain? What is it removing, or why is it circulating? What can you find in it?
you can find infections and things in it.
If you get a brain infection, you can find that. You can find breakdown products of neurochemicals. We tend not to find anything that's that interesting to us other than a differential diagnosis to rule out brain infections. The spinal column, segments divided into parts are defined by the vertebral foramina through which the spinal cord passes. So there are 8 cervical segments, 12 thoracic segments, 5 lumbar segments, 5 sacral segments, and 1 coccygeal segment. The roots of the spinal column, pass out of the spine in pairs, with the dorsal pair, 1 dorsal pair and 1 ventral pair for each vertebra. The dorsal root ganglia are primarily sensory, receiving sensations of touch, temperature, and pain. And the ventral roots are predominantly motor, with some pain also. But if you think about it, the brain is simply, it's organized the same way. And a brain is simply a puffed up spinal column. And the way we got to have this brain this puffed up is because we are descendants of organisms that had a rudimentary spinal column that gradually, through evolutionary history, got more expanded with more elaborate functions at the top end. But the organization of our brain is organized geographically in the same way the spine is organized geographically.
Just sensory in front, motor in back.
Yeah. Now, the reason there's such a thing as dermatomes, you know what dermatomes are?
Uh-huh.
And the reason they are the way they are is what?
The way the spinal cord projects nerves as it descends.
Yeah, that's right. So you can tell, you actually know this band that runs across here comes out of which vertebrae in my back. And you can look at the dermatomes and see if in fact somebody has a pain with no lesion or a numbness with no lesion here, you know exactly where that nerve is being pinched in their back. Is because the dermatomes are organized that same way with very little overlap in those bands. So somebody comes in and they have a rash that runs on one side from here down to there. What do you think that would be?
Shingles.
Shingles. And why is it in that band?
That's the dermatome that's infected.
The infected dermatome, so it's the nerve in that dermatome that is infected. Okay.
Can I give you a little aside? You
Sure.
were asking for the pronunciation of Magindi,
Yeah.
and I think that's the right pronunciation.
Thank you.
Just pronounce it that way. So.
Yeah, but I found out about who that was. He was a nasty dude. This scientist was known for vivisection and like cruelty to animals, live vivisections in front. He's the one that founded this area or whatever. That's why it's named after him. But he was not a nice fellow.
Well,
We'll remember that.
we'll put him on the list with the guy who invented the frontal lobotomy and a lot of the early surgical procedures done without anesthesia, I think, including the craniotomies that were done by the Aztecs. They used to do craniotomies to let the spirits out, I think. So,
Trepiding?
yeah, and the interesting thing is, you know, people survived those. That's interesting. That's by virtue of the dura mater, isn't it? Protected that brain. By golly. Okay, here we go. We're going to get to a break in about 15 minutes. Okay, cord is organized in layers. What would be expected by inspection of the dermatomes? The layers carry particular kinds of sensory and motor information. An examination of the cross-section of the spinal cord shows a pattern that is vaguely shaped like an H, with the upper limbs called the dorsal horns and the lower limbs called the ventral horns. The horns carry information from ganglia, so that the dorsal horns carry sensory information and the ventral horns carry primarily motor information. So those are the laminae and what they carry. Knowledge of the major neuronal pathways and their functions, including second messengers. The primary sensory cortex, the thalamus, the medial temporal lobes, and the basal ganglia. The primary sensory cortex receives sensory information from the sensory module, the sensory organ, and the thalamus. The association cortex integrates information to represent sensory experience by integrating information from the primary cortices, the subcortical structures, and the brain areas affiliated with memory. There are 6 layers in the brain. Layers 2 and 4 contain small interneurons, and they are GABAergic cells. They don't project very far, and they inhibit the functioning of the brain. Layers 3 and 5 contain pyramidal cells. They're glutaminergic, so it's primarily glutamate is the neurotransmitter. They're excitatory, and they collect input and project to other cortical and subcortical areas.
Is GABA both excitatory and inhibitory? Just inhibitory?
Primarily inhibitory, yeah. And the reason GABAergic medications affect almost everything is because what they're doing is inhibiting the layers, that layer in the brain globally, all over the brain. And so they basically slow down neural function in all of the higher cortical areas of the brain. And the reason we don't seize is because we have enough GABAergic activity to inhibit the brain and counteract the glutaminergic excitation. And the glutamate levels excite neurons and turn on regions of the brain in order to activate activity and function in those areas. And our brain has this ongoing kind of balancing act going on between these glutaminergic layers that are excitatory and the GABAergic layers which are inhibitory. And so the reason you seize, if in fact if you have developed a tolerance to a benzodiazepine and then you withdraw from it too rapidly, the glutamate excitation of those layers precipitates a seizure. And so messing with the GABA system that inhibits the brain, you can see why that in fact has a kind of a global and potentially deleterious impact on brain function. For the brain to work, it has to localize activity and turn one area on at one time, another area on at another, and so the brain is constantly balancing the turning on with glutamate and toning it down with GABA in order to localize the activity that's required to function. The cortical structure and function. Cortical neurons are targets from other cortical areas from the thalamus. So the higher cortical areas are where inputs come to be sorted out, recognized, interpreted, scanned, assembled in order for us to appreciate reality and to be able to function. They're targets from the thalamus also, and from neurotransmitter-specific projection areas like dopaminergic neurons from the ventral tegmental area and serotonergic neurons from the raphe nucleus. And they all modulate the function of the cortical areas. So this higher cortical area of our brain, that top layer, has these projections coming from these various systems, and it's being turned on and off, and that's why on PET scans you see a little area of the brain lighted up, And that's a combination of glutamate turning it on, GABA not inhibiting it, and projections from these other systems, from the dopamine system, from the serotonin system, in order to activate that area of the brain to process information. Modulation by dopaminergic and serotonergic systems. Dopaminergic receptors D1, D4, and D5. D1 and D5 impact the pyramidal cells, and D4 impacts GABAergic interneurons. And then the serotonergic system is 5-HT2A.
What about D2?
I'm sorry?
What about D2?
D2 is deeper. It is in the, it's deeper in the pyramidal system. It's basically in the brain stem. So the D2 blockade is lower down in the thalamus, beneath the thalamus, and that's part of the reason you end up with the extrapyramidal cycle. The thalamus is a portal for cortical processing of all incoming sensory information. And the thalamus, there are relay nuclei pass information from the sense organs to the primary sensory cortex, and the association nuclei establish reciprocal correlations with the association cortex. And the motor nuclei relay input from the basal ganglia to the motor cortex. The basal ganglia integrate inputs from the cortical motor areas, modulate the activity of the thalamocortical projections, and create a corticostriatal thalamic loop that includes the ventral striatum, the dorsal striatum, caudate and putamen, and the globus pallidus. The basal ganglion, the dorsal striatum, integral to the corticostriatal thalamocortical loop. I'm having trouble even reading this. Involved in the generation and control of motor behavior. By the way, I haven't had to think about this much as I'm prescribing. I mean, this is a little too deep for the consideration when you're actually picking a medication for the patient. Ventral striatum connects to the amygdala, hippocampus, and hypothalamus, part of the limbic system, involved in reward and expectancy, modulated primarily by dopaminergic neurons, D1 and D2 receptors. The medial temporal lobe integrates multimodal sensory information for storage and retrieval from memory and attaches an emotional limbic meaning to the information. And that contains the amygdala, which is prominent in anxiety, hippocampus, prominent in memory, connected to limbic system, emotional valence to memory. So this is why, since we attach an emotional valence to memories, this is why when you're doing psychotherapy, you actually know the patient's getting somewhere when they begin retrieving memories that have the same emotional valence. And so they go through a chain of associations connected by that emotional valence. And that's when you know what they're bringing up is organized based on the similar emotions that have been elicited by the experiences they're talking about. And why a current experience is reminiscent of prior kinds of experiences. And so there are other ways to organize what one produces, and you as a therapist know this intuitively, that the patient's not going anywhere if they're not following trains of association that are connected by emotional valence. That if they're, just to say it, they're coming up with every time that they can think of where they met somebody new. And, or they're telling you about their favorite the vacations they took from year to year. Where did they go each year on a vacation? Well, that is mildly interesting, but not anything connected with their real sharing of their heart, of their emotional experience. Yeah.
And how is that helpful by them sharing those connections?
Well, it's we think it's because if they haven't really connected that up and lined it up, they in fact can have their decision-making captured by something pulling up that emotional valence and affecting their decision-making without their really being aware, why is it that I really gravitate to this or avoid that? Why does this light my fire? Why does that cause me to shrink away?
And by sharing those memories or experiences, does that lead to any physiological changes in the brain, or does it affect any particular brain structures?
Well, you're going to be making new dendritic connections that will be related to appreciating that. And Jamie Pennebaker, when he wires people up and monitors them physiologically as they're undergoing psychotherapy, says that when people are actually working in psychotherapy in an effective way, that you will see that they're actually relaxing. Their blood pressure comes down, their physiological signs of stress are reduced at the end of that process, that it releases stress and releases tension that seems to be associated with that sort of sitting there without really being connected. So, yeah, that's sort of basically what Pennebaker thinks about it, really.
My question was about deja vu.
What about it?
Well, that feeling like you had been somewhere before, that you remembered something, not necessarily related to you actually having been there before, doing something before, but just a sort of a feeling of recognition of the situation that you're in. And so that, to me, is a real good connection between the hippocampus and that limbic response, that feeling of familiarity, even though it's not.
The best
Hi, I'm
explanation.
Nicole Lamont, Columbia University.
So, the best explanation I've heard of deja vu is, in fact, we are always matching our incoming inputs with memory. And sometimes, and that takes milliseconds. And sometimes the experience I'm having right now is stored before I'm consciously retrieving, checking to see how does it match with memory, and when my brain checks, it finds that the experience is already there. And so it makes me appreciate this moment as if I've been there before, because I actually was there before a millisecond, and the time it takes for me to consciously process it lags slightly behind the time it takes for me to store it in immediate memory to have those traces stored. And so it's that sort of mismatch in the timing that causes deja vu. Okay. One minute. Remember 4 systems of tightly packed neurons that project to all areas of the brain, modulate the functioning of these areas of the brain. They are cholinergic, dopaminergic, noradrenergic, and serotonergic. And those are our big 4, aren't they? They're the ones that we play with. These are the ones we are affecting. What we're trying to do primarily, aside from D2 blockade and stabilizing neurotransmission, is to soup up or alter those major projection systems that go to the various regions in the brain. These are the ones that we're fine-tuning with our psychotropic medications. GABAergic neurons are primarily inhibitory, and glutaminergic neurons are primarily excitatory. Why don't we give people glutamate if they're kind of sluggish? They'll seize, and glutaminergic overexcitation of neurons kills the neurons. And this is why seizures, the actual experience of seizure, having seizures, is neurotoxic. Just because the seizure itself, the excitation that comes from the glutamate. And this is why with seizure disorders, historically we've noticed if they're not treated properly, that they tend to get worse because they are producing neuronal damage that actually makes the likelihood of further seizure even greater. So now it's time for a 15-minute break. Basal forebrain and brain stem, two main types, muscarinic and nicotinic. The nucleus basalis of minor, located in the basal forebrain. Axons project to the hippocampus and the amygdala and throughout the neocortex. They mediate memory, learning, problem solving, and judgment. And so you'll see in Stahl, chapters 6 and 7, brain regions and corresponding disorders. And I'm citing the 3rd edition. I don't know what edition you folks have. I left Stahl. Is it 4th now? We'll look at the chapters on brain regions and corresponding disorders. Knowledge of the vascular supply of the brain and the blood-brain placental barrier. The blood supply to the brain. There are 3 routes that our cardiovascular system uses to send blood to the brain. The 2 internal carotid arteries and the vertebral arteries. And the vertebral arteries connect together and become the basilar artery. And then there are anastomoses at the circle of Willis where they all come together. So the basilar artery and the 2 internal carotid arteries connect to the circle of Willis. So we have a redundant system for sending blood to the brain. And that's pretty cool. If you think about it, this is, not all of what we have is intelligently designed, but some of it's intelligently designed. Hey, that's a pretty cool design, don't you think? That, okay, you cut off the blood supply from one internal carotid artery, and you don't really miss a beat. The blood continues to flow from the other internal carotid artery and up the basilar artery and in the circle of Willis, and keeps your brain alert and running. It's only when you get enough occlusions in those arteries that it begins to matter if you get one fully occluded. But for most of our lives, we have that redundant system, so you will, even if you cut off circulation through both carotid arteries, your brain will stay alive because the vertebral artery and the basilar artery will send blood through the circle of Willis and supply the brain. It may not support consciousness, but it will certainly keep your brain alive until the blood is, the circulation is restored through the carotid arteries. So now you see, it's pretty cool. I think you can see here the basilar arteries coming up here. They're the vertebral arteries to the basilar artery. And here you'll see internal carotids right here. They're cut off. So you see they would be coming up here and plug right in there. Okay. So now, what is this right here? Middle cerebral artery, and we're looking at the top of this person's brain, so it's which one? The right or the left? Left. So that is the left middle cerebral artery. Okay, and notice that the interior carotid, the left carotid, comes right, connects here, goes into the circle of Willis, and then the middle cerebral artery takes off right there. Why do you suppose it is that the most common stroke is an MCA occlusion? A middle cerebral artery occlusion. That's the MCA. Why is it the left MCA? Why is that the target? Most common stroke is one of those that hits the left middle cerebral artery and causes hemiparesis and aphasia. So the symptoms of aphasia are caused by what? By the occlusion of the middle cerebral artery. So these areas of the brain are not being fed, so they underfunction or die. And the contralateral side of the body, there's a paralysis. Why is it that that is the most common stroke?
Because the heart is on the left side, and the aortic arch, where the pressure in blood throws the blood up through your carotid arteries, it's more likely to throw the clot up that left side, and then as the blood flows around, it's more likely to fall into those first sides first.
One of those branches up there, somewhere here, sort of gets stuck as it gets smaller. But why now? You're saying it's more likely to go up the left than the right carotid artery. Why is that?
I may be wrong, but I think it's because of the heart being on the left side and the way the arch comes over and down and feeds blood up the carotid arteries.
Yeah, the carotid actually takes off at the top up here, so your heart's right here, and the carotid,
So you're going to throw a clot.
aorta, is coming up and arching this way, and so that it's more direct route, it's more straight up, and that's why. And so the left MCA is the most common kind of stroke.
So you had me totally thinking I was crazy, because you were looking at me like I was crazy as you were saying that.
Me? I would never.
But also on this image, I don't see a right side cerebral artery.
Because it's
The right middle cerebral artery, it's tucked right under there. See, this is the right temporal lobe. It's kind of peeled off. See, it's cut off here. Here is the left temporal lobe. It's cut off.
I see.
So you can see the middle cerebral artery there. This should come up like this.
So they actually have one on the
And
inside.
there's there. So it's tucked right under there, and it would be tucked right under there.
I actually have a picture of a brain that has one of those MCAs, like after that hole that forms in the brain after all that tissue dies. It's just devastating how much damage it causes. It's surprising people survive it.
Yes, it's amazing. And men or women survive better.
I'm going to guess women.
Why would that be?
Because it's tougher?
They're better, basically, in everything.
They're neurologically superior, for one thing. It's true. It's true. I mean, you look throughout the lifespan. What is it? Have you ever looked at a Y chromosome? It's kind of a stubby little thing. Don't you suppose there's some missing genetic information? There's some missing genetic information. X chromosome. Look at those. Those are nice, big, long things. That Y chromosome's a stubby little. All it has is turn on your testes and produce testosterone and do stupid stuff. That's all that. That's all that white.
It's not
I mean,
really.
Frank?
We got to find out to record this.
It is being recorded. Whoops. No, this is actually probably true. And then secondly, the corpus callosum is larger. Women's brains are better integrated. Women survive strokes better and recover from strokes better than men do. So it looks like neurologically the brain's a little better integrated in women, and it's testosterone poisoning.
Like
Probably.
able to share function between the sides better, so
Yes.
that when one side gets shut down, the other side can take over better.
So it's testosterone poisoning. Okay? But it's a better way to live. You know, to have all that testosterone. It's a short, glorious brain out. Oh, well,
Supernova.
I think I'm ill. I think the virus has gotten to my brain. If I were female, my brain would be working better. Okay. So, I think that's just kind of cool that you now understand that, and this is a pretty good diagram of blood supply. Okay, knowledge of the cellular and molecular nervous system biology and regulatory process. We've talked about that. Knowledge of major neurotransmitter and neuromodulator synthesis, storage, release, distribution throughout the brain and the rest of the body, action, reuptake, and degradation. Well, that's the whole story of this. We've been talking about reuptake blockade. You know a lot about this stuff. From axonal to synaptic transmission, the action potential reaches the synaptic bouton at the end of the neuron, depolarizes the bouton and causes a release of neurotransmitter from the presynaptic vesicles, which are docked. The receptors, the autoreceptors and postsynaptic receptors, are activated, and the response of the presynaptic neuron is terminated. Now, I think I talked with you folks about the autoreceptors being the off switch, and I don't need to review that again. Synaptic transmission, it's of most interest to psychopharmacology. It's not the whole story, but we're doing modulation of synaptic transmission is really mainly what we're doing with our psychotropic. Chemical neurotransmission, there are three forms: endocrine, paracrine, and synaptic. And the structure of the synapse, there are presynaptic structures, the synaptic bouton, synaptic vesicles, secretory vesicles, and docking complexes. And the postsynaptic structures, there's the synaptic cleft and the postsynaptic density. The synaptic vesicles are formed from endocytic invaginations of presynaptic membrane. So the way that synaptic vesicle that's going to be filled with neurotransmitter is formed is the wall of the bouton folds in on itself and closes and then fills with the neurotransmitter. Secretory vesicles, they're fewer and larger than synaptic vesicles. They're derived from the Golgi apparatus, and they contain peptides. So the neuropeptide substance P that also acts as neurotransmitter, that is, in fact, produced in secretory vesicles in the neuron. Docking complex, it looks like a ship docking area. So if you look at it with an electron microscope, it looks like that the synaptic vesicles are actually plugged into what looks like a docking area where you would dock ships. And it's highly structured hexagonal protein grid, and the size of the grid matches the size of the synaptic vesicles. The vesicles, they line up with the grid, they appear like docked ships, and they're present in all of the chemical synapses. And the space between the synaptic bouton and the postsynaptic cell, it's got little filaments that hold it. It's not like the ends are just kind of floating around free. They are connected with these fibers that kind of hold them in proximity to each other. And the filaments bridge the gap, and they bind the cells together. Then the postsynaptic density is the receiving area on the postsynaptic neuron, and it appears like a dense area in electron microscopy. It indicates it's the site where the information transfer occurs, the receptors. So it's kind of rich with those receptors. Chemical released by the synapse binds to target receptors, and the function of the synapse can be modified by the chemicals that alter its receptivity. Neurotransmitters are synthesized in a neuron, and specific neurotransmitters are built for specific kinds of tasks. Neurotransmitter synthesis is dependent on enzymes as well as molecules to be modified. And the rate at which the neurotransmitter can be built is limited, and the step most likely to limit the production is called the rate-limiting step. and the rate-limiting step is of interest in neuropsychopharmacology. So write down in your book, rate-limiting step, remind myself, look up what is the rate-limiting step of each of the 4 major neurotransmitters. What's the rate-limiting step in the production of dopamine, norepinephrine, serotonin, and acetylcholine? Now, the only real reason it's interesting, I mean, the neurotransmitter is being produced by chaining together these proteins, cleaving them, rebuilding them, plugging them together, and the rate-limiting step is the substance that is in the least supply, and so you can't have more of the neurotransmitter than you have of whatever that substance is that is the rate-limiting step, and that puts a cap on how much of that neurotransmitter you can have.
Do you also need a certain amount of protein in order to?
Certainly do.
Because they're all proteins, right?
Yes, our body, our liver, our metabolism can do very wonderful things in reconstructing chemicals that come in and creating chained proteins and their enzymes and processes that do that. And a biochemist knows all about that, and I'm not one of them. And so I'm not going to say any more about it. But do look up the rate-limiting steps.
More than one is what you're talking about, right?
And for each neurotransmitter system, there's a rate-limiting step. So what is the rate-limiting step in the production of serotonin?
Okay, I just want to make sure I understand what you're talking about. You're talking about because a lot of the neurotransmitters follow the same metabolic process, right? So tyrosine turns into dopa, dopa turns into dopamine. Is that what you're talking about?
So what is the rate-limiting step in that process?
It's tyrosine hydroxylase, decarboxylase, like those things that break them down and make them into the next neurotransmitter.
So specifically, you want to Google the rate-limiting step in the production of dopamine is.
So for serotonin, if this says
5-HTP.
tryptophan availability is the actual rate limiting factor.
So it's tryptophan or serotonin.
It's 5-HTP, right? Specifically,
serotonin.
5-hydroxytryptophan.
Yes, that's the rate-limiting step. Now, why, if you eat a whole lot of 5-HTP over the counter, why don't you all of a sudden produce mega doses of serotonin?
Because you still have to break it down.
And because you digest it, and so it doesn't get into the production
But
of
you could,
5-HTP.
you could theoretically eat a whole bunch of turkey, right, and get a lot of tryptophan.
Yeah.
But you still have that rate
There's a
limit,
limit to how much you're going to absorb.
right, because you only have so much.
So all I'm asking you to do is memorize the rate-limiting step for each of those 4 neurotransmitter systems. And it is for your own good, because you may be asked that on the PEP. Because everybody makes such a big deal of this.
Why?
That's a good question. It certainly keeps you mindful of the fact that it's a construction job to build a neurotransmitter.
Okay.
And you've got to have the building blocks. And there is some building block that is least likely to be available. And it may well be a naturally selected paucity of that in order to keep you from producing a neurotransmitter willy-nilly. So you found it for serotonin. So we'll go on. That's a homework assignment. Okay. Synaptic transmission, presynaptic action potentials lead to calcium entering into the presynaptic neuron, Therefore, calcium channels are voltage gated. The results in rapid increases in calcium next to the vesicles holding the neurotransmitter. The presence of calcium allows the docking of the vesicles to take place. So that action potential opens up those calcium channels, calcium rushes in, allows the docking. The process of the release of the neurotransmitter then is triggered. That's exocytosis. The exocytosis results from the vesicles fused with the presynaptic membrane basically breaking open and spewing the neurotransmitter into the synaptic cleft. It is stopped by inactivation of calcium. And the calcium is isolated by systolic proteins in the neuron, moved into storage cisterns by systolic proteins, and transporter molecules pump the calcium back into the interstitial space by the use of calcium-sodium pump. So there we have how that process is going to take time. And this is another reason why there's a limit to the speed with which neurons can transmit signals from one neuron to the next.
The interstitial space, that's the space between the neurons, right?
That's right.
Where most of these glial cells?
Well, it's water outside the cells. I mean, we've got a bunch of interstitial fluid. That's one of the compartments of fluid compartments. Remember, we've got intravascular fluid, we've got extravascular fluid. The extravascular fluid is in part our what are these things right here? These lumps, these bumps?
Lymph nodes?
Lymphatic system, and also the interstitial space that there's between the cells, there's fluid, that's interstitial. And so that's a compartment. And some of our chemicals, some of the stuff we put in people, can get into that interstitial space and hang around. So there are, you think in terms of the fluid inside of a person, the intravascular, extravascular, and at least two compartments in extravascular, which is interstitial and in the lymphatic system. Okay, vesicles which have emptied are recycled, and the recycling moves the vesicle away from the Bouton membrane and back to the interior of the neuron, where it fuses with cistern in the endoplasmic reticulum, where it picks up more neurotransmitter, and neurotransmitter is built in the endoplasmic reticulum. Say it with me. Neurotransmitter is built in the endoplasmic reticulum. Because that's the kind of question, if there was just a fact-based retrieval question on the PEP, that might be one. Synaptic transmission. Secretory vesicles release neuropeptides in a manner different than synaptic vesicles release neurotransmitters. The release can occur almost anywhere on the neuron, and the release can affect synaptic and paracrine signaling modulating. Secretory vesicles release neuropeptides with a higher firing rate of action potentials. So substance P and some of these neuropeptides, they don't come into play until there's a higher firing rate. Co-transmitters. Multiple neurotransmitters can be released by the same neuron. So there can be more than one kind of neurotransmitter produced in and released by the same neuron. And then there can be differential release of the transmitters due to differential firing rates. Small molecule transmitters respond to low firing rates, and large molecule transmitters released at higher calcium levels with higher firing. Synaptic inhibition. Release of neurotransmitter may be inhibited by the stimulation of presynaptic receptors like GABA and alpha. Action of neurotransmitters on postsynaptic neurons must be terminated. The termination is brought about by diffusion away from the synapse, reuptake of the into the pre or postsynaptic neuron, or the neurotransmitter is degraded by an enzyme that is in the synaptic space. And certainly when it is taken up in the pre or postsynaptic neuron, it can also be degraded by enzymes. True neurotransmitters. So you might be asked this on the pen. What is a true neurotransmitter? Build-in neurons present in boutons released after an action potential, bind to specific receptors, and inactivated by a specific mechanism. Norepinephrine, epinephrine, dopamine, 5-HT serotonin, acetylcholine, GABA, and glutamate. There are two kinds of receptors. Ligand-gated ion channel receptors that are fast, and G-protein-linked receptors. They are slower, and examples are cyclic AMP and somebody pronounce DHE for me. Diacylglycerol, and arachidonic acid, and 9 others of less relevance to psychopharmacology. Knowledge of neuropeptides, enkephalin, endorphin, substance P. Knowledge of the endocrine system and the interface of various hormones and other neurotransmitters. The endocrine system components are the pineal gland, hypothalamus, pituitary gland, the anterior, the thyroid gland, parathyroid glands, thymus gland, adrenal glands, pancreas, the endocrine part of the pancreas, and the gonads, testes and ovaries. Function is a regulation of metabolism, growth, developmental changes, homeostasis, and reproduction. Works with the nervous system to regulate responses to the internal and external environment. It's primarily a story of hormonal control. Hormones are chemicals derived from amino acids, lipids, and peptides. 3 kinds of chemicals are released: local hormones known as cytokines, neurotransmitters, and circulating hormones. Local transmission. Hormones released from cells cause a response by receptor binding. They're released into the interstitial fluid and cause effects either to the same cell or to adjacent cells. Examples of local hormones are the prostaglandins, the histamines, and growth factors. Neurotransmitters. In terms of the function of the endocrine system, the neurotransmitters, circulating hormones released into the blood and circulate to cause histamine effects. Affects only cells with the appropriate receptors, operate in a feedback system for homeostasis, either positively or negatively. Key points about hormones: they work in positive and negative feedback systems. They're released in response to stimulation of the nervous system. They can be unbound water-soluble forms or protein-bound lipid-soluble forms. What about the receptors? They are found extracellularly and intracellularly. They can up or down regulate. That's a key concept in understanding the effects of some drugs like the SSRIs. Endocrine system has several types: G-protein linked, like thyroid stimulating hormone, and glucagon, and ion channel, which are the fast. The thyroid gland is located in the neck, can be palpated when the person swallows, Why is that? Because when you swallow, your thyroid gland is lifted up, right? So you can feel yourself when you swallow. You can feel the top of your thyroid gland. Nobody wants to play? Okay.
Well, we had to do it in the physical examination.
You did it?
Oh, yeah.
Okay. So you've been there, done that, don't care. That's why you're not primary care docs. All right. Can be palpated, produces hormones for the control of metabolism of carbohydrates, fats, and proteins. Thyroid releasing hormone is stored in the hypothalamus. Released the anterior pituitary where thyroid stimulating hormone is stored. TSH is then released into circulation where it binds to receptors in the thyroid and increases the release of stored thyroid hormones T3 and T4. So therefore, it stimulates the release of thyroid hormone. The hypothalamus turns the hypothalamus turns on the anterior pituitary using TRH. Anterior pituitary turns on the thyroid using TSH. The thyroid increases thyroid hormone synthesis, releases stored T3 and T4, the two thyroid hormones, increases iodine uptake and oxidation, and increases synthesis and secretion of prostaglandins. Thyroid hormone increased thyroid hormone release increases the rate of carbohydrate, fat, and protein metabolism. Thyroid hormone is necessary for growth hormones' effectiveness in stimulating normal growth, and it inhibits the production of thyroid-releasing hormone and thyroid-stimulating hormone. That's that negative feedback. The effect of aging. We have an increase in hypothyroidism because of atrophy of the thyroid gland, fibrosis in the nodules, T4 secretion declines, and TSH secretion declines. So it's harder to detect thyroid disease in older adults. A measurement of thyroid function. Okay, lab testing when we get there, we'll look at that. Hyperthyroidism, you'd think, well, it should speed up metabolism, and so it'd be a good weight loss technique, wouldn't it? And in fact, some weight loss centers have used thyroid extract, driving up somebody's level of circulating thyroid hormone in order to induce weight loss. But it also causes cardiovascular problems, heart problems, bulging eyes, and naturally occurring hyperthyroidism. Usually you see a hypertrophy of the thyroid gland, a goiter. Hypothyroidism causes mental dullness, reduced heart rate and stroke volume, cardiomegaly, prolonged PR interval in the cardiac cycle, non-pitting edema, and hypotension and hypoventilation. Definitely not good. The pancreas is both an endocrine gland and an exocrine gland. Primary functional unit of the hormone secretion is the islet cell of Langerhans. It's innervated by the autonomic nervous system. And islet cells secrete insulin and glucagon. Insulin from beta cells increases glucose uptake into cells, increases liver's uptake of glucagon, and glucagon from alpha cells counteracts the action of insulin. Now notice the innervation by the autonomic nervous system. So if we are giving somebody a procholinergic medication, then we are stimulating pancreatic function. Procholinergics induce parasympathetic arousal. if we're blocking, if we give acetylcholine, do something to block acetylcholine, anticholinergic medications, we are impairing pancreatic function and making potentially diabetes worse in patients who have diabetes. And a lot of our medications are anticholinergic. So, this is the end of that section. Can I hear a, that's a wonderful thing? That it's over? Well, we've gotten to 3 o'clock. So now we're going to do content area 3. We'll give it a moment till these folks come back. Or shall we? What are you thinking? Want to stand up and turn around?
Sure.
Oh,
That's how you do the hocus pocus. Alright, now I'm going to send you guys.
Oh, we've got Casey McDougall says she's given us a reference.
It's a he, and we've sent it to everyone.
He.
Sasha, did we send it to
Of course.
Marlon
Yeah.
too?
Right, I mean, that's,
Okay.
yeah, but that doesn't answer your question. I mean, that's the thing, but, that's the homework that you just assigned a minute ago?
Yeah. So the real limiting factor for that one is hydrogen hydroxylase. Doesn't he give you all of them? I don't know.
Say it again?
I don't know if it gives you all of them.
No, it doesn't give you serotonin.
Actually, it does, but
Oh, further down?
that's actually the document I was looking at.
Okay.
Oh, okay. Good. Got it. Got that committed to memory? Yeah.
So I just sent
Bill, a bill for your consultation.
No.
This is when you're in the answer. Could you, wait and turn down.
Thank you, Casey.
No, I had to read the picture.
I
Remember?
I know that's how you learn when you teach.
Access to the slides. Tonight, Sasha will post a link to the recording. It will always be in the box.
And that really saves costs.
That would be
Foundation.
Bringing that comparative into what we did.
Are you moving to Iowa for a job?
No, in iteration 6.
And why it's got a chance in Idaho and Nebraska. Okay, refers to disorders of the nervous system resulting in abnormal function or behavior mood disruption. Includes biochemical, structural, meaning congenital or acquired, or neuropsychological anomalies and their impacts on other body systems. Knowledge of the etiological factors and diagnoses of dementia, delirium, and other cognitive disorders. Dementia. Incidence increases with age. Affects 15 to 20% of people over 65. 45% over age 80. Reversible in only about 15% of the cases. And the most common causes are cardiovascular disease and Alzheimer's. That's one of the key differentials, is what seems to be driving the condition. Because if it's cardiovascular disease, sometimes you can ameliorate the factors that are causing the microvascular damage and can interrupt the process. We don't see a lot of, right now, a lot of progress in intervening with Alzheimer's type dementia.
Is it really reversible?
Which,
Dementia.
yeah, it can be reversible. It depends on what the cause is.
Yeah.
Yeah. There are 248 different causes the last time I looked. And some of them are metabolic. Some of them are metabolic anomalies that if they're corrected, then the person's cognitive function improves.
Maybe it's a diagnostic question in my head, because is that then where they suffer from dementia?
Yeah, well, yeah.
It's not the way you think of dementia, but it is dementia.
You're thinking of irreversible cognitive decline. It has to be irreversible. No, it doesn't. No, it doesn't.
I mean, that's just.
Yeah, it doesn't have to be
I routinely
irreversible.
think about it.
Yeah,
Because I would think of the other as more like a delirium state. I mean, with the exception of the rapid onset and all that.
Yeah, that's, the problem is, no, dementia is a steady, substandard cognitive performance. And so, and it can be reversible in some cases if you correct the underlying condition. Vascular, stroke, chronic subdural hemorrhage, post-anoxic injuries, and with infection, HIV, neurosyphilis, progressive multifocal leukoencephalopathy, PMLE, Creutzfeldt-Jakob disease, tuberculosis, sarcoidosis, and Whipple disease, neoplasms, primary metastatic carcinoma, paraneoplastic syndrome, and degenerative Alzheimer's, frontotemporal dementia, Lewy body dementia, Parkinson's, progressive supranuclear palsy, ALS, corticobasal degeneration, and MS. Inflammatory, vasculitis. So here would be a case where you can have a vasculitis that when it is treated, the dementia improves, the symptoms of dementia improve. Endocrine, hypothyroidism, again, and adrenal insufficiency, if you treat that, you may get an improvement in cognitive function. Cushing's syndrome, hypo or hyperparathyroidism, renal failure, and liver failure. And then metabolic causes, thiamine deficiency, Wernicke's, vitamin B12 deficiency, and again with thiamine deficiency, you'll see an amelioration of the dementia symptoms if you actually give the person thiamine. And with vitamin B12 deficiency, if you replace the B12.
Wernicke,
Korsakoff's.
what's that?
Korsakoff's?
Korsakoff's, yeah, is that reversible? Korsakoff's?
Vitamin B12, right?
Partially reversible.
Yeah, I guess you see the
Depends
symptoms
on,
improve.
like, I thought it was irreversible when I first started treating it, but there are doses of vitamins that you can give, especially if they stop drinking, you can recover some of the memory function. Like, I was first taught that it was irreversible, shut the door, it's done.
Yeah, permanent psychotic kind of.
But I've seen people get better. I've seen people with Wernicke-Korsakoff's, like, get some of their memory function back.
Depends on how early in the process it's treated.
Toxins like chronic alcohol use, drugs, medication effects, heavy metals, trauma and other, like dementia pugilistica, normal pressure hydrocephaly, obstructive hydrocephaly, medical illnesses with psychological presentations, neurologic diseases, subdural hematoma, normal pressure hydrocephaly, seizure disorder, post-concussion syndrome, Alzheimer's disease, Cuff's disease, rare genetic disorder.
Are these the 30 they wanted us to know? The 30 medical disorders?
These are, yes, these are neurological primarily.
Okay, but not the full.
The risk factors for Alzheimer's, increased age, positive family history. 50% of those with first-degree relatives whose positive will have disease by the age 90. History of head trauma and Down syndrome. It's a very common occurrence in individuals who have Down syndrome to develop Alzheimer's type dementia in their 30s and 40s. And it's a pretty common thing with Down syndrome. Early symptoms, loss of short-term memory, word finding and naming difficulty, apraxias, things like trouble remembering what was that system again with the little lumps here? Yeah, that might be an example. Impaired judgment, correlated psychological symptoms, depression and anxiety. I would think it would be extremely anxiety provoking to not recognize where you are and who you're with. That wouldn't be cool. And so that would be, I think, very, very unsettling. And it's the fate of people with Alzheimer's.
Have you heard about some of the treatments at Alzheimer's treatment centers where, because emotional memories tends to last longer, they will, like, two of the things that were described. One was every day they would have two of the staff dress up and have a fake wedding. And the other thing they would do is they would bring like a new baby, like
I have heard of that actually, yeah.
And then the patients would stay in a good mood the rest of the day.
Mm-hmm.
They wouldn't know why,
Yeah.
and they couldn't say why,
Yeah.
but they would continue to function well.
Such a more positive emotional tone. That's a pretty common thing for memory units to do, to have a birthday party for somebody every day. And they can have it for the same staff person. Everybody eats cake and has a good time. Risk factors for vascular dementia. These are the big ones. Hypertension, hyperlipidemia, diabetes, arrhythmias, vasculitis, TIAs, smoking, and obesity. And interestingly, these are also risk factors for Alzheimer's. These all increase the likelihood of Alzheimer's. So let me just segue here and tell you that there is an article published in Science that it was an article based on a set of research studies. It was very difficult for the authors to get it published because it was so off the assumed cause of Alzheimer's that it wasn't published by a number of scientific journals, but Science published it. Science is a heavily respected scientific journal, refereed. And what these researchers noticed was that the plaques in Alzheimer's look like the same plaques that the intrinsic immune system wraps viruses and bacteria systemically in as the intrinsic immune response to an invasion. And so they theorized that what might be happening is that as the blood-brain barrier gets leakier, there may be low-grade infections, herpes being one, that the brain is then using the intrinsic immune system to wrap those viri in plaques, and so that it's actually low-grade brain infections that stimulate the production of the plaques that result in Alzheimer's. Now, they did research with mice very prone to develop these brain plaques, the mouse analog to Alzheimer's, and they demonstrated that they could stimulate the production of those plaques by infecting those mice. And so it's a series of studies that show that connection. And they're arguing that certainly there are genetic propensities to produce more of those plaques or less, but the reason that people who have better cardiovascular health, who are generally healthier, don't have hypertension, are more physically active, are less prone to develop Alzheimer's, even if they have the genetic predisposition to do so, is because it's really the leaky blood-brain barrier that is allowing that low-grade infection. Now, whether that turns out to be true or not, it'll be interesting to see. But it certainly won't be on the PEP exam. But I just thought you might want to know that coming down the pike is a new way to look at. Now, there's medications that are being studied that will, in fact, use the immune system to remove plaques, hoping that that will improve the symptoms. But the mechanism that causes Alzheimer's is still something that has really is controversial and being studied, and there are a number of routes. And this is just a very novel approach to trying to understand the development of Alzheimer's disease. Okay. So the reason I mentioned it is because if you look here, hypertension, hyperlipidemia, diabetes, arrhythmias, vasculitis, TIAs, the first few of those are related to cardiovascular health and to the also the development not only of vascular but of Alzheimer's type dementia. So what do you do in a way of a medical workup for dementia? A CBC and look at the SED rate, chemistry panel, thyroid stimulating hormone level, VDRL. We had a patient in, I think I may have told you, in the psych unit who he was diagnosed as schizophrenic, and we interviewed him, and he was talking about how much he loved his girlfriend in Juarez and that the place she lived in, and so we got a little further into it and discovered that he used to visit this house of prostitution, and it turned out that the guy had nobody done a VDRL, and he was having actually general paresis from the late stage of syphilis. Yeah. Syphilis. And so he wasn't really schizophrenic. I mean, he appeared schizophrenic, but he was misdiagnosed. HIV assay, urinalysis, serum, vitamin B12 and folate, chest radiograph, electrocardiogram, CT or MRI imaging of the head. Now, that's the high dollar, high road workup for dementia. Most people don't get all that. But in general, in our clinic, yeah, they probably get all of it. If we are thinking about diagnosing them with dementia, and with an Alzheimer's type dementia, they probably have all of these tests.
What are they looking for on a CT scan?
CT scan, the larger ventricle spaces. So you're seeing brain atrophy. You see that with Alzheimer's. So the brain actually appears to shrink.
And you would be in early stages and not see it?
Yeah, oh yeah, you won't see it. But you're also then looking for anything else ugly in the head. You know, as my colleague, Dr. Stephanie Benson said, you look for an SBI, something bad inside. So you're just looking to see if there's something bad in there. Okay, decline in cognitive function. With Alzheimer's, you see a slow decline in cognitive and behavioral ability. And the treatment is acetylcholine esterase inhibitors and also memantine, Namenda, which is neuroprotective. How well do those work? Nah, not very well. I prescribe them, but I don't. And I see people improve a little bit, but it's not exciting. The amount of improvement is simply not exciting. It produces some symptomatic improvement, and as long as people feel a little better and feel like they're functioning a little better, I think that's fine. But you pay a price with the side effects of the acetylcholine esterase inhibitors. And then if it's normal pressure hydrocephaly, you'll see gait disturbance, dementia, incontinence, enlarged ventricles without atrophy, and a ventricular shunt is the treatment for that. With multi-infarct dementia, you'll see focal deficit, stepwise loss of function. And you're seeing that with oftentimes a vascular type dementia. You treat the atherosclerotic risk factors and identify and treat thrombi if they appear. And with Parkinson's disease, you see extrapyramidal signs, tremor, rigidity, cogwheel rigidity, slow onset. Treat that with dopaminergic agents. HIV infection, you'll see systemic involvement and positive blood tests for HIV. Treat whatever specific infections there are. Neurosyphilis, you'll see optic atrophy, Argyll-Robertson pupils, gait disturbance, positive cerebrospinal fluid serology. Treat with high high-dose IV penicillin, with multiple sclerosis, brainstem signs, optic atrophy, long-standing disease, MRI findings. Use recombinant interferon and corticosteroids. With intracranial tumors, focal signs, papilledemia, seizure, corticosteroids to reduce intracranial pressure and treat vision. Do you use, as a neuropsychologist, an ophthalmoscope on you ever
I am
check
now.
their, I'm sorry?
I am now.
You are now? Okay, good. Okay. What are Argyll Robertson pupils? According to Wikipedia, I wanted to cite my reference. Bilateral small pupils that constrict when the patient focuses on a near object. They accommodate with near vision, but do not constrict when exposed to the bright light. They do not react to light. They are a highly specific sign of neurosyphilis. So if somebody had bothered to shine a light in this guy's eyes, actually do a physical exam and do a neuro, the guy in our psych unit, they would have known that he was suffering neurosyphilis because he would have had. And you can see a video of what it looks like when you click on that link. Another 1 minute of fun as you're studying for the PEP is you get to look at that. Delirium, acute onset, course fluctuates, level of consciousness and attention impaired. Characteristics, there's the acute onset, usually worse at night. Why is that? But why is there such a thing? Why do we have sundowning? What?
She whispers.
I do, because,
Speak loud.
well, there's a number of different theories. So the pineal gland and circadian rhythm is one.
And what does the circadian rhythm do that might affect the level of consciousness?
Can you rephrase where I understand the question?
Okay, so you got a circadian rhythm, and what does it do? What is it about the rhythm that would affect the level of consciousness?
Sleepiness, wakefulness cycle.
Yeah. So it's activation. It is a reticular activating system, and your brain is turned on to a greater extent. There's more glutaminergic excitation during the day. And it's also the case that flooding your retina with light also increases the activity of the reticular activating system. This is why you use light in phototherapy to perk up depressed people who have seasonal affective disorder. So you're seeing people with delirium. Delirium is under-functioning of the brain. I mean, it's not quite turned on well enough, and so it's not sorting out what's real and what's not. And you give them a stimulant, that'll perk them up, and they'll be less delirious, and light, less delirious. So basically, it's turning the brain on and the fact that the brain kind of slows down at night. When are we most likely to have heart attacks? That's right.
At night,
At what time of night?
when you're sleeping.
What time when you're sleeping?
Heart attack or stroke?
Heart attack. Probably stroke too. When are you most likely to have a heart attack and stroke?
Early morning hours.
Early morning. Early morning, 5 o'clock.
Pressure starts to go up.
Your energy, you've just been asleep and now your energy comes up. So your highest heart rates, blood pressure are peaking and coming up in the morning. So heart attacks and strokes, they happen 4 or 5 in the morning. Okay, so delirium, acute onset, we did this, night worse, disorientation, inattention, impaired cognition, disorganized thinking, delusions, altered circadian pattern, perceptual distortions, hallucinations, and illusions. What can cause it? Drugs. We can cause it with our psychotropics. Alcohol withdrawal, metabolic problems, renal, hepatic, endocrine, infections, neurological causes, increased intracranial pressure, encephalitis, postictal, and strokes can all cause delirium. Etiological factors and diagnosis of chronic pain, including headache, differentiation of pain syndromes, with primarily nervous, musculoskeletal, and tension-related etiology. Nociceptive pain. Pain sensors conduct signals of potentially damaging stimuli. It's caused by stimulation of nociceptors signaling injury. And then there's neuropathic pain, central, MS, stroke, spinal cord injury, and peripheral. It may be caused by diabetes, metabolic conditions, shingles, herpes zoster, and other infections, nutritional deficiencies, toxins, immune disorders, and physical trauma to the nerve. Acute pain mobilizes the sympathetic branch of the autonomic nervous system. You don't see habituation yet. So if somebody comes in and tells you they are in acute pain, you should see elevated blood pressure and heart rate. And it may be highly elevated. And with chronic pain, the person habituates, and so you don't see sympathetic arousal with chronic pain. But you can use the sympathetic arousal to determine whether or not a person is accurately reporting acute pain. There's less sympathetic arousal, persists beyond healing or longer than 6 months. There's no well-defined neurological mechanism. May be categorized as a DSM-5, somatic symptom-related disorder. So how do we treat it? Well, looking at the severity on the left side with low-level severity up to higher-level severity. For neuropathic pain, low level, TCAs or SNRIs. And the reason for that is all of them increase norepinephrine a little bit. And norepinephrine then may bring gating in the pain chain of pain receptors. With nociceptive pain, NSAIDs, especially if it's an inflammatory pain. We can also use with neuropathic pain something like pregabalin or gabapentin, and for nociceptive pain, acetaminophen, if it's not inflammatory. And then if
pregabalin on our formulary?
I'm sorry?
Pregabalin's on our formulary, but gabapentin's not?
The truth is, they're both in the hospital, the drugs, facts, and comparisons in the hospital formulary listed as psychotropics. However, our New Mexico rules say the medication has to be FDA approved for a condition in the current DSM. And we've had a DSM change. And so has that DSM change, in fact, changed our formulary?
The entire ICD-10.
No, the DSM is
DSM-5 is supposed to match ICD-10 codes.
supposed to, but our law says it has to be listed in the DSM. And so you can't say, well, if it says it in the ICD and it corresponds to this DSM code, therefore it's DSM. You may say that,
They won't respect it.
but this is, I don't know.
Okay.
This is where we're a little bit out on a limb
Yeah.
because we don't have a best practice formulary,
Okay.
which permits us to use what's usually used as a psychotropic nationally, according to drug facts and comparisons and the hospital formulary. What it says has psychotropic use, we ought to be able to prescribe any of that. But our law in New Mexico does not permit us to do that. So you may proceed at your own peril. Okay?
I don't like peril. Not bad.
Yeah, okay. Well, you may as well just fold that up. Just back up and just kind of,
You seen Monty Python and the Holy Grail, right?
oh, yeah.
It's a little peril.
Yeah. And then for the more severe pain, neuropathic opioids, and for nociceptive opioids. Now, that's even controversial now, because the opioids don't work that well for pain, and the downsides are pretty dramatic in terms of addiction and damage to people's lifestyles. Medications, behavioral side effects. What happens with TCAs? Well, sedation, fatigue, urinary retention, dizziness. With SNRIs, insomnia, dizziness, somnolence, fatigue, GI complaints. With gabapentin, pregabalin, dizziness, somnolence, ataxia, fatigue. Tramadol, dizziness, somnolence, and the opiates, somnolence, constipation, dizziness, dysphoria, or euphoria. Most common goals in pain treatment: increase physical activity. Independently, increased physical activity improves pain management. Reduce the BMI if appropriate at dietary change. Stress reduction, CBT mindfulness, breathing exercises, improve mood, reduction in dysphoria if a person is depressed, and anxiety, improve sleep, smoking cessation, reduce substance use if appropriate. Remember that we have, our central nervous system has a capacity to have upregulation and downregulation. And for chronic pain, the assumption, one of the functional assumptions is that we've had, because of the suppression, remember, our brain doesn't like for us to not be able to feel anxiety because it's adaptive from an evolutionary point of view. Our brain does not like for us to not be able to feel pain because it's adaptive from an evolutionary point of view. And so both those systems can upregulate and hypersensitize those transmission lines. And so one of the theories, and it's probably likely to be borne out, is that you're seeing hypersensitization of those pain tracks in patients that have chronic pain. So it is the person becoming hypersensitive to low-grade signals that as they start out. Okay, somatic pain from nociceptors and peripheral tissue, usually well localized, described as stabbing, aching, or throbbing. Visceral pain from nociceptors and bodily organs is usually poorly localized and usually described as dull or crampy. And both are conducted through spinal thalamic tracts, and they're modulated by an endogenous analgesic system. We have 18 endogenous peptides. Remember, the opiates are exploiting this endogenous opiate system. So what they're doing is basically plugging in to the receptors in that natural opiate system. Why do we have that endogenous opiate system? Why do we have a system that will make us less pain sensitive? And that is, in fact, mobilized by the sympathetic branch of the autonomic nervous system.
Protection.
Well, in fact, it allows us to keep fighting if we're injured. So we have an endogenous opiate system that desensitizes us to pain sensation, and it's adaptive so that we can keep going if we're under attack or are injured. So it makes us pain insensitive temporarily. And so how many of you have ever experienced, been a long distance runner, and all of a sudden, you were just about to run out of gas, you felt like crap, and all of a sudden, you just began to float. And you didn't feel your body anymore, and you felt like you could just run forever. That's when you've done enough damage that your endogenous endorphins come online. That's
I think this is a myth.
That's the one. That's you do enough damage, tissue damage, you stimulate the dump of those endogenous endorphins, and then all of a sudden you hit this runner's high.
That rat-based system we were talking about.
And when it's endorphins. It's the raphe system that stimulates the endorphin dump, and you're good for a while until that wears out, and then you crash. Then you can't run anymore, and you feel like crap.
Is it similar to people who've been injured, like, and during a crisis, they don't really notice
Yeah.
until after?
Yeah, that's that
Even people
endorphin.
who've been shot, you know,
Or
That's right.
self-injury,
That's right.
or purging, or things like that can have a similar sort of effect.
I had a guy who was shot in the chest. I'm coming into the forest preserve, and he's coming out with a guy who's kind of assisting him, and the guy's car's on the other side, and he's got a hole in his chest, and he is hopping, man. I mean, so I get him in my car. Oh, he says, he's so mad. He's yelling about, if I could have gotten a hold of that kid, I would have knocked him, and the kid pulled a gun on me and wanted my wallet, and he's madder now. And he's got his hand here, and he's got some blood coming down here. He wants to drive to the emergency room. I said, there's no way you're driving to the emergency room. Get in my car. So I take him, drive him over to the emergency room, and, he's just mad as a wet hen. The whole way he's just grousing about, if he catches that kid, he's going to pound his face in, How dare he do this and this kind of thing? So I get him in the emergency room, and it's under construction. And so I have to drive around the hospital trying to find where do you take somebody in. There's nobody at the emergency entrance. There's a wheelchair out there. So I get the guy out, put him in a wheelchair, and I roll him in, and these two nurses, this is kind of a low level, it's not, this is not a crisis center hospital, this is South Suburban Hospital. They're not used to big crises there, and there are a couple of ER nurses there who see this, and man, they tune in right away that this is not good, okay? So we roll him over to the bed, and he kind of dives in there, and I said, now look, I want to call your wife, so give me your wife's phone number, this guy. And the guy, he nearly died. I mean, he was very close to death, but because of this endorphin system, he was up and running and feeling no pain. And he didn't even seem to have that much trouble breathing, even though he had a hole through his lung from this bullet that had gone into his chest. So I'm telling you that to explain that, oh yes, as a matter of fact, you can run on nearly dead without knowing you're injured. And a lot of you probably have been in situations where you look down later and see, I'm bleeding, what happened? How'd that happen? Well, here's one right here. I'm at the health club, I don't know how I did it, but they complained that I was bleeding on the machine. You shouldn't bleed on the machine. I understand that's a rule at the health club now. You don't bleed on the machines. Okay. All right. Okay. So, categories: acute, self-limited, correlated with healing, associated with objective sympathetic arousal, and chronic, persist beyond healing or longer than 6 months. No well-defined neurological mechanism, lacks signs of sympathetic arousal. And people who have chronic pain, it's usually present in people with premorbid depression, anxiety, personality problems. And we think it's likely to be this hypersensitivity syndrome that's functioning there. Categories: continuous and terminally ill due to physical pathology, may be exacerbated by stress, sleep deprivation, depression, personality structure. Neuropathic: injured or dysfunctional central peripheral nerves. It's spontaneous, sharp, shooting or burning sensation, usually distributed along dermatomes. And I had a guy who he basically had his leg removed and had phantom pain, and then he didn't have any phantom pain for 20 years, and then he got an infection and had a recurrence of the phantom pain that it infected apparently that nerve, and so then he had phantom pain again, and he was mad about that. I don't mind it. Reflex sympathetic dystrophy, RSD, now called complex regional pain syndrome. This stuff is weird because it is pain that seems to be maintained by the sympathetic nervous systems localizing a mobilization of the immune cascade and inflammatory cascade in a region of the body. So my patient who had RSD, if you couldn't touch his leg, or barely touch it, but if you measured the temperature, one of his legs was 20 degrees warmer than the other leg. The leg that was in pain was inflamed red. When the RSD would kick up, you'd see it looked almost like his immune system was attacking that portion of his body. And it's a painful, extremely painful process. And they've done all kinds of things to try to intervene, including putting people in the hospital, anesthetizing them, and keeping them under anesthetic for 48 hours to see if they can get it to settle down and quiet down and reverse that. And I don't know where research is on RSD or CRIPS at this point. Idiopathic pain, no demonstrable organic cause, and phantom pain distal to an amputation. Usually it disappears after 2 or 3 years. Concomitants of pain, mood disorders, headache. The majority of headaches are migraine, cluster, and tension type. Common, 90% of people experience occasional headaches. So this is a very common complaint in the family medicine center. And we're going to take a 10-minute break, and then we'll do the last hour. We're going to try to finish this section. She was on anticonvulsant medication, and they also diagnosed her with schizophrenia because she had auditory hallucination. So she's on a mood stabilizer, or on an anticonvulsant. She's on risperidone. Well, she started lactating on the risperidone. She's now a college student and lactating. And she's still having auditory hallucinations. And I had switched her to a different antipsychotic and ran the dosage up a little bit. Did not help. She still had auditory hallucinations. At least she said, yeah, I hear voices. Oh, there's something weird going on here, because the thing you learn is if something usually works and it doesn't work in this case, think I've misdiagnosed this person. So I'm with her one day. She came in and I asked her again about, well, have you been hearing voices and when do they happen? And she said, I don't hear them all the time. And sometimes I hear them afternoon. I hear them sometimes in class. It's, it just comes at random times when I hear these voices. And what are they saying? Well, it's random. Are they accusing you of things? Are they, what kind of things do they say? Well, I'll hear my name sometimes and I'll hear people talking. And it's just there's no real pattern to it. And I'm sitting with her, and all of a sudden, she kind of leaned over in the chair like this and looked at me and then didn't move. And so I called her name, and she was looking at me, and it was like she could look straight at my eyes, but she didn't seem like she could move. And so I said, can you move? And she didn't say anything. And so I reached over and kind of picked up her hand, and her arm and hand were kind of relaxed, but she wasn't waxy. It wasn't like I thought, well, maybe she's got catatonia. No waxy flexibility. She was just limp, kind of slumped over. So I went and got the
Eyes open still.
Eyes open looking at me. I said, wait right here, I'm going to go get one of the primary care doctors. I went and got Dr. Ewing. He's this old, used to be a residency director, country doctor, seen everything, 75. I said, I need to have you come in and see this patient. She appears to me to be paralyzed. And we were just talking. And he said, oh, okay, well, let me come in. So he walked in and he looked at her, and I told her what her name was. He addressed her by name and said, can you hear me? And she looked, she didn't really look at him, but she didn't seem to move. And so he kind of picked up her hand and held her hand and kind of patted her hand, talked to her and said, this is going to be okay. We'll try to figure out what's going on. And so he told me later he was trying to feel if there were any sort of micro contractions in her hand, because I'd said to him, I don't know whether this is feigned. I don't know. I've not seen her do this before. And he said, no, because if somebody's feigning that, you're still going to feel them contracting your muscle. So we called the paramedics, and I stayed. And I said, well, I'll stay with you, and I'm going to meet you over in the hospital. Called the paramedics, and they came, and they lifted her up, put her on a gurney, hauled her over to the hospital, got her in a bed. She went to sleep, and when she woke up, she could move again. Okay, so I said to her, how often does this happen? She said, well, that's a seizure. I have seizures.
Yeah.
And I said, well, really? This is what you're calling a seizure? This is what people have said is a seizure? She said, well, yeah.
Does she remember anything?
Oh, yeah. She remembered. She remembered me being there. She knew. She thought she was going to have a seizure, but she couldn't move. And I thought, okay, this is not a seizure. And then I began talking to her more about the auditory hallucinations. And they tend to occur more when she was drowsy. And so then I said to her, well, tell me about how you sleep at night. She had kind of a irregular kind of sleep pattern. And it turned out that she had narcolepsy with cataplexy. And she'd been misdiagnosed from the age 7 to college. And so she'd been medicated as if she had a seizure disorder and schizophrenia, when what she had was narcolepsy, and these were hypnagogic and hypnopompic hallucinations associated with narcolepsy. And then she had cataplexic episodes that were misdiagnosed as seizure, when in fact she had a sleep disorder. So we got her a sleep study, and sure enough she had a sleep disorder, and what she needs is a stimulant medication during the day to regularize her sleep pattern, because the issue was that she wasn't sleeping at night and she was dozing off, and you either use modafinil or one of the straight stimulants during the day to help the person stay awake in order to...
But then you got to be careful how you're coming off the other meds.
Took her off of them right away.
No withdrawal syndrome or anything?
No.
How did you know it wasn't a seizure?
Well, I would expect with absent seizure that she wouldn't have been present to me and wouldn't have been able to tell me everything that happened.
Yeah, she wouldn't remember.
And she was aware of what, she was just paralyzed with this limp paralysis. And people with cataplexy, if you'll see videos, even YouTube it, you'll see somebody walking down the hall who's got cataplexy, they're walking down the hall, they just collapse. And they're awake, but they can't move their body. And it is sleep paralysis happening while the person's awake. It's that mechanism that we have when we go into REM cycle sleep, which is a sleep paralysis that happens. And you could imagine that'd be kind of unnerving. So anyway, that's my story.
What was the outcome?
Well, she's doing fine. She's doing better in school because she's not dozing off. And she's not being sedated by being on anticonvulsant medication that is sedating, that was making it worse, and she's not on an antipsychotic medication that's sedating, which is making the narcolepsy worse. So in fact, the treatments were making her worse. And so she's doing a lot better.
I know seizures are so many different kinds. Do all of them involve either movement or contractions of some kind?
No, an absence seizure can look sort of like that, but usually you'll see sometimes a little movement in the person's mouth, and they are absent.
Well, I actually
And she
had a
was
patient
present.
I had a patient who actually had an episode like that in session with me, and he just got up. He was talking, and then he just stopped in the middle of sentence. He got up and walked out. So that to me is still, he had no memory of this later. You know what I mean, about what happened.
That sounds more like a temporal lobe epilepsy, where the person begins taking an action. Is that right? Let's get our neuropsychologist in here.
I thought
Yeah,
he told
I
me
don't
that he
really
had
see
absence.
movement like that though, the seizures.
He actually was speaking a little bit. He even got
I
up
don't
and
think
left.
we have.
He left the office. I was like, what is going on?
Temporal lobe epilepsy can look like, the person can act out, they can go on automatic, and you can't really dissuade them,
Right.
and they're not really present with
They're not
you.
rational.
Yeah,
It wasn't, there was
Well,
nothing.
it depends on where the seizure activity is localized. But in her case, she wasn't seizing, she was having sleep paralysis.
See, I
while
was
she was awake.
thinking one way to tell if it's not a seizure, it's complete paralysis. Is there any seizure that happens where there's like no movement, like you check to see, or is there always some kind of?
I don't know the answer to that.
So, what was the full question again?
Jonathan, I'm sorry. One of the students online says the only way one can conclusively say epilepsy is a manifestation plus a change on EEG.
And you only get abnormal EEGs in 65% of the people who have a seizure disorder.
But they have to be having the seizure while they're being monitored
That's
on
right.
an EEG. So
That's
an
right.
EEG is essentially useless
50%
if
of the
they're not
time it's
having,
inconclusive, right? I mean,
if they're not having changes in brainwaves. So,
I'm just wondering if there's any seizures that ever don't have any kind of movement or contraction. That to
you
me
can have
was a sign
staring
that
spells like the absence seizures. I mean, sometimes it's just a kind of a staring spell. But how you differentiate a seizure from any other type of abnormality is their awareness. Are they responding if they're having, and an absence seizure is very limited time frame, so it's not going to last for 10, 20, 30 minutes.
Right.
So if you can, say, Gabe, and you get their attention,
or she can remember it later. Then
and
you
there's
know
a
that
memory
that's
or
not-
recollection of it, I mean, you might want to think pseudo-seizure maybe, or something else like, the case was now.
And John says, no, simple partial, no LOC.
No loss of consciousness. So simple partial would be what you are describing could be a simple partial, and what could be a temporal lobe, simple partial. But it's dangerous to diagnose, that way, except if you're trying to think of the differentials. The reason I had the impression when I was in that room with her, and she was looking at me, that she was trying to communicate something with her eyes.
Mm-hmm.
I had this sense that she was still trying to connect with me, even though she couldn't move. And it was a sort of weird, it was quite odd, as you can imagine.
She could remember what happened?
Yeah, oh yeah.
And is that because the eyes don't get anesthetized by that sleep action, and that's why she could kind of move her eyes?
I don't know, but if you think about REM cycle sleep, it's rapid eye movement.
Yeah, right.
I don't know well enough to know whether to answer that question. Whether you would expect with a cataplexy that a person would still be able to move their eyes some. I don't know. Okay, other sleep disorders, apnea. Okay, what's the problem with apnea? What's the biggest risk of sleep apnea?
No REM?
The biggest risk, the long-term consequences of apnea are not breathing.
Cardiovascular disease?
And what's the mechanism?
Puts your heart in a different rhythm.
I would guess.
No, but you keep guessing. This is good. Remember that the vascular system in the lungs, the arteries in the lungs, are the one place where, if there's not oxygen present for transport, there's constriction of the vasculature. And that's a natural protective mechanism to isolate pockets of infection. So if you get an infection, so you've got a pocket of infection, your lung will isolate that by constricting the vasculature around the pocket of infection. So, and that's because there is restricted oxygen flow at that point. If you have sleep apnea, you have constricted oxygen flow throughout your entire lungs. And so you get vascular constriction in your lungs, pulmonary hypertension, which causes tremendous pressure on your heart, on the right heart, and so you have a cascading problem of right heart failure that causes left heart failure. So it is the pulmonary hypertension due to sleep apnea that causes cardiac failure, and it's a real substantial risk of apnea. Sleep apnea is no laughing matter because it will induce cardiac failure because of that mechanism, because of the pulmonary hypertension. Okay. Other
Pulmonary
disorders.
hypertension?
Hypertension. Remember, what's the blood pressure typically in the pulmonary system? It's 120 over 80.
That's right, I knew that.
Systemically, it's 120 over 80. And what is it in the pulmonary system? It's a lower pressure system. And it's around 20 millimeters of mercury. And what you're doing, if you run that pressure up, remember your right heart is not as big and as strong, and you're creating this back pressure on your right heart, and so then it's the adaptive mechanism is you get cardiac hyperplasia and cardiac failure,
Right.
and the right heart failure cascades to left heart failure, and you end up with heart failure due to hypertension or to apnea. So when you have patients who have CPAPs and they don't like to use them, and they give you that bull crap about, oh, it's so uncomfortable, and all it means is I'm not sleeping well, and blah, 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 blah. Well, you're going to die young with a cardiac failure if you don't treat that properly, if it's severe apnea.
And the best treatment is the CPAP machine.
Or whatever a sleep study has determined you need in order to intervene and stop those apneic
When
episodes.
Julian taught us, he was saying something about it's just people are overweight and that's what causes sleep apnea, and he had like kind of short shrift for it.
He was saying that the fat.
Yeah, like the fat in the throat closes.
Well, sure, that exacerbates it. That exacerbates it, but gee, that's it. You deserve to die from cardiac failure because you're fat? No, I mean, it's a serious, ugly thing, and there are very thin people who have sleep apnea.
Right.
And so it is, though.
You remember that, right?
I mean, I worked in the Navy, and there's a lot of patients that have, sleep apnea, and they're skinny.
Yeah. Right.
Yeah.
But I
It's pretty
remember,
severe,
you remember
too,
him
like
talking that way,
13.
though, right?
Well, it can increase, and one of the ways you can screen is to look at neck size, because the larger the neck size, the more likely the person is to have apnea. But you don't have to be overweight to have sleep apnea, and it is a very serious illness. So that's
Yeah, they just look at the next size. They look at the Epworth sleepiness scale.
yeah.
So that's always got to, like, we can do that and put that on the note. So, like, explaining, like, hey, probably likely to have this. So that's what they want us to do, especially at the hospital. If we suspect that they have sleep apnea, we have to do those things and put it in notes, and we're more likely to take care of it.
So I live in my 100/400, and I just saw a guy who wanted bipolar drugs, but he has uncontrolled diabetes and he has uncontrolled sleep apnea. And I said, we gotta get these other things under control before let's get back to your primary care physician and other things like that before.
If you were going to prescribe for it, what would it be okay to give it?
I should have kept my mouth shut. I don't know off the top of my head.
Bipolar,
Mm-hmm.
what is the classic medication you use that would not induce weight gain?
Emoji? No.
Lithium is least likely.
Yeah.
I mean, it may induce a little bit of weight gain, but if you were going to use anything, you'd probably use lithium.
Okay.
Because you would not want to use some of the other mood stabilizers or second generation antipsychotic, which you can use as a mood stabilizer, but would induce weight gain. But no, getting that treated, and so that he's sleeping better.
I just want to see what symptoms are left after those two things get cleared up.
Oh, yeah, and don't hold your breath on how quick they'll get cleared up.
Because I'm just not, I mean, I went through a symptom history and it was hard for me to find clear indications of bipolar
Sure,
that weren't
sure.
related to.
Just sleep deprivation?
Exactly
Oh,
right.
absolutely, yeah.
Exactly.
You're probably wise in saying that. Don't assume this is really bipolar disorder. So no, I'm just kind of being a theoretical.
Yeah, you busted my
gadfly
chops a little
here.
bit. Yeah, I got you.
So, other dysomnias, periodic limb movement disorder and restless leg syndrome.
Is that the same thing?
No,
But the,
RLS is different, regular.
I thought the name got changed, but it's actually two different things.
I think they're two different things. Maybe not. Somebody correct me on this.
I thought the DSM-5 changed it to periodic limb movement disorder. Isn't that what we learned from
And Leah
From,
Billington had said that too.
Dr. Yeah, Billington?
Is that right?
That's what, it might be wrong, but that's what I thought.
I think it kind of, the ICD-10
Maybe it's that.
puts it under there. So she was indicating that the DSM-5,
Yeah,
we could actually, because ICD is the same code,
right.
something with other.
Okay, so Leah taught you about sleep disorders?
Yeah, well,
Well, just
No.
this part for gabapentin, I think it was.
Oh.
it was just because, yeah, we were talking about what could be prescribed
Right.
based on DSM. And restless leg or periodic limb disorder is now in the, as being in the DSM, you prescribe, I think it was, for anxiety, she would do gabapentin.
I don't remember.
I can't
So the
remember.
DSM has the periodic limb movement
For anxiety.
5.
Okay?
But this wouldn't be on the PEP anyway because it's new.
Yeah. Parasomnia is disturbance of a particular stage of sleep, wake sleep transition, hypnagogic jerks, light sleep, non-REM sleep disorders like sleepwalking and night terrors, REM sleep disorders, nightmares, and REM behavior disorder. Okay. Sleep disorders related to psychological conditions usually involve insomnia rather than hypersomnia. Psychotic disorders, oftentimes a person has problems with sleep initiation and maintenance. Sleep time is decreased and disturbance in REM sleep. Affective disorders, early morning awakening is the most obvious and most common. Person can get to sleep if they wake up, can't stay asleep. REM is decreased. A minority of very depressed folks experience hypersomnia. And with anxiety disorders, there's problems initiating and maintaining sleep. Knowledge of the etiological factors for Parkinson's, Huntington's, and Tourette's. Parkinson's, degeneration of dopaminergic neurons in the substantia nigra. A classical triad of tremor, rigidity, akinesia, or dyskinesia. I mean, there's not an absence of movement, there's problems with it. Huntington's causes degeneration, dysfunction of basal ganglia circuitry, and the cause is autosomal dominant trait, 1 in 10,000 or 10 in 100,000 of the general population. Tourette's, male to female ratio 3 to 1, there we go. What did I tell you about that Y chromosome? Cause is excess dopaminergic activity in the basal ganglia, associated with motor and focal tics, and coprolalia and echolalia only in 10% of the cases, even though you saw it in the movie, that old classic movie, which was about the possession. What did it do? Came out in the 70s. It's The Exorcist.
The Exorcist.
Exorcist is an actual case of a young lady who.
So a friend of mine's daughter recently got diagnosed with this, and the pediatrician and the neurologist said that she would maybe grow out of it. Is that a common thing?
You mean the frequency with which people grow out of it?
Yeah.
Yeah, I don't know.
I never heard people growing out of it before.
I don't know. Let's check. Would you follow up on that with us tomorrow and tell us? Okay. Knowledge of etiological factors and diagnosis of mental retardation, and knowledge of etiological factors and diagnosis of neurodevelopmental disorders like FAS, pervasive developmental disorders, Fragile X. You know the bands for mental retardation or developmental disabilities. Etiology, 40% no clear cause, 350 specific causes known. The three most common are Downs, Fragile X, and fetal alcohol syndrome. Pervasive developmental disorder similar to autism but with a later stage of onset, characterized by abnormal social relations, bizarre mannerisms, and variant of autism. And even though the language has changed with the DSM-5, the PEP is DSM-4, DSM-4-TR. Knowledge of etiological factors and diagnosis of CNS vascular disorders. So CVAs and transient ischemic attacks. The CVAs, sudden or rapid onset of neurological deficits in a vascular territory that lasts longer than 24 hours and due to an underlying cerebrovascular disease. Transient ischemic attacks last less than 24 hours. The etiology, when there are two kinds of causes. There's the ischemic cause, which is a blockage. So there's a reduction of blood flow due to a blockage. And then there's a hemorrhagic cause where there's a bleed. So it's either a block or a bleed. Atherosclerosis can cause a block. Hypohyalinosis, 20% also called small vessel disease caused by lacunar strokes. And cerebral emboli, 20% are from a cardiac source. Knowledge of etiological factors and diagnosis of seizure disorder. Okay, we talked some about this already. So I'm going to let you look at those. How many of you know about AVMs? What are AVMs? They are likely to present when what happens? When there's a bleed. So you get an arteriovenous malformation. It looks like kind of a knot and a tangle of blood vessels in the brain that are incompetent because, it's sort of a genetic or a structural anomaly that causes incompetent blood vessels that have a tendency to bleed. And so you'll usually find out about this when the person develops a brain bleed. They develop symptoms, they go in and get a CT scan, and they discover that there's an AVM. Seizure, paroxysmal abnormalities in brain function associated with abnormal electrical discharges from neuronal aggregates. Systemic pathophysiological processes like fever can cause it. And it's not unusual for fever to cause seizure in children and in the elderly. And the reason for that seems to be that it's an achievement to maintain a brain that has a balanced level of activity and a balance between glutaminergic excitation and GABAergic inhibition, and if you're a child or if you're an older adult, your brain just may not be able to keep that act up as well as when you're a young adult. Systemic pathophysiological processes, metabolic derangements like hypoglycemia, toxic reactions, brain lesions, and brain injury all can cause seizure. There's a comprehensive description at that link. There are the types, and temporal epilepsy, unprovoked episodic behavioral changes, trance-like appearance, on-off shifts of consciousness, stereotypical movements of the face and neck, episodic discontrol, unprovoked spells of violence associated with an altered state of consciousness, precipitated by alcohol or minor tranquilizers. Knowledge of traumatic brain injury, 1 million severe TBIs in the USA, motor vehicle accidents cause 50% of them, falls, sports, and violence cause most of the other 50. Symptoms are determined by the size and location of the damage, with penetrating head injuries, with closed head injuries, diffuse symptoms, prolonged course, neurobehavioral dysfunction, cognitive, somatic, and emotional symptoms. Symptoms may resolve by 6 months or persist, caused by direct impact, acceleration, deceleration, shearing, parenchymal stretching, microscopic tears, result in brain contusion and neuronal damage exacerbated by edema and bleeding, limbic stress, anterior temporal lobes and inferior surface of the frontal lobes especially vulnerable, the limbic areas. Closed head injury, persistent symptoms, you'll see cognitive slowing, attention deficit, distractibility, memory difficulty, poor executive function, irritability, impulsivity, depression, anxiety, and mood lability. And with somatic symptoms, headache, dizziness, fatigue, sleep disturbance, photophobia, noise sensitivity, tinnitus, and blurred vision. Exacerbation of closed head injuries, multiple injuries, advanced age, drug or alcohol abuse, sensitivity to psychoactive medications. Which of our medications is most likely to induce seizure? Get a seizure warning on which meds? Bupropion, and what else? And the norepinephrinagic agents?
SNRIs?
So it's duloxetine and venlafaxine and bupropion and what?
I was just saying SNRIs, but.
Yeah, that's right, SNRs. Post-concussive syndrome, prolonged duration of cognitive, somatic, and emotional symptoms following head trauma that cause significant cerebral concussion. Knowledge of other nervous system pathology, MS, infectious disease, neoplasms. MS is the most frequent of the demyelinating disorders. 50 to 60% of demyelinating disorders are MS. ALS is 1.6 per thousand, is fairly rare, and then there are lipid storage disorders. How many of you have worked with ALS patients or MS patients?
I haven't.
MS and? MS. Anybody with ALS? I had a series of ALS patients in my mid-career that once I worked with one, then I got another, and then I kind of got a little specialty in that. And I only had one at a time and needed a recovery period of about 6 months between patients because that is a really ugly way to die. And
Which one? I'm sorry.
ALS, it eventuates in the locked-in syndrome where the person is unable to move at all. And their brain is still working pretty well usually, so they're aware of what's going on.
And Stephen Hawkins is a more rare kind.
Very
where
slow. Oh,
it
yeah.
doesn't die.
Usually it progresses a lot faster than it is. And then brain tumors, neoplasms, general symptoms, headache, seizure, drowsiness, limbic system, strong emotional discharge, disturbance of instinctive behavior, on-off shifts in consciousness or perception. In the frontal lobes, there are two patterns, apathetic depressive, and antisocial manic. You see a loss of bladder control, shortening of walking steps, deficits in vision and smell, and catatonic reactions. Neoplasms. 50 to 60% primary tumors are gliomas. They tend to produce diffuse symptoms like cognitive decline. Meningiomas, 25% of primary tumors. I did tell you I have a meningioma. This is why never get overstudied. I got Meniere's disease, so I didn't have balance, and I was vomiting and all that sort of stuff, so I have a workup. So they do a brain scan. And first, the guy's, he's just walking through this routine, and everything's fine. And then he says, so how are you doing? I think we need to do this one scan again. You doing okay? So tell me about how, And I thought, oh shit, he found something. Well, he did. I have a meningioma, which is small, and I've been evaluated now. I've had to go back annually and have my brain scanned so it's not growing. But here is the hazards of over-testing somebody is test anybody, you're going to find something, and then you got to follow up, and you got to keep looking at it, and potentially treat it, and the treatment may hurt the person more than, well, anyway, the good news is there's no sign that it is malignant at all, and I've had several follow-ups, but it costs huge money and costs me a day to go in and have this darn brain scan. And this is why when we're doing lab testing for our patients, we have to be judicious about what labs we order.
Why do you keep doing it?
What?
Why do you keep doing it?
As long as they tell me, the neurologist tells me, now you're on this annual schedule, we're going to just scan your area. Don't think about it till you come back next year. So unless I tell you about it and notice this and it reminds me, I don't think about it. But I'm going to do it as long as I'm told I need to do it, because there's some small risk that it could start growing and it would produce symptoms. It's asymptomatic, and it's an interesting picture. So I ought to include the picture of my brain. How many of you have proof you have a brain? Really, I have proof. Okay. Knowledge of neurobehavioral psychological disorders that have a hypothesized neuropathological basis. Schizophrenia, affective disorders, anxiety, and ADHD. Notice they're saying disorders that have a hypothesized neuropathological basis. Anxiety, they listed. This is the APA people. So, this is neurobehavioral, and I'm going to let you read his slides all by yourself. Okay? So I have included his slides here for you and given him attribution. Now, knowledge of the mechanism of extrapyramidal dysfunction, dystonic reactions, and dark tardive dyskinesia, acute dystonias that are medication-induced, slow tonic sustained muscle contractions, affects the face, neck, tongue, jaw, whole body sometimes. The cause is extrapyramidal effects, blockade of D2 receptors. 90% of these acute dystonias start within 3 days of treatment. Tardive dyskinesia usually starts after 6 months to a year. Potentially irreversible extrapyramidal hyperkinetic movement disorder causes long-term administration of dopamine blockade. Our best theory is that the cause is you're hypersensitizing those dopamine tracks by doing the dopamine blockade. But we don't know for sure, but that's the prevailing theory, is that there's upregulation again and hypersensitization. Frequently affects the mouth and tongue, lip smacking, sucking, facial grimacing, chorea-like movements of limbs. Symptoms worsen with emotional arousal. 10 to 20% of patients treated with neuroleptics for more than 1 year can develop TD. Clozapine neuroleptic is the least likely to cause tardive dyskinesia. Zyprexa is the second least likely. Seroquel is the third least likely. Risperidone is the fourth least likely. Because they all are anticholinergic and antihistaminic. And so what they do is treat the pyramidal system and suppress extrapyramidal side effects, which may reduce the likelihood of developing this sensitization syndrome. There's one more slide. Are you ready for it? Akathisia causes neuroleptics, SSRIs, TCAs, and lithium. It's a restless urge to move. Subjective experience of quivering muscles. It's like a full-body restless leg syndrome. And I have induced akathisia in a patient with Abilify. 20% of patients on Abilify develop akathisia.
And then it goes away as soon as you take it off.
Or once you add something to suppress, it's an extrapyramidal symptom, so you add a cholinergic or histaminic medication, but I typically will take the person off of it and then switch to something like Seroquel. So, any questions before we go?
I've got a lot of questions, so I'll ask them more.
Okay. Thank you all. You are troopers. You're welcome. 9 o'clock tomorrow morning. Be here or be square.
You know you're not getting into me, right?
I do what?
Like, you're gonna teach the rest of this class, but I'm gonna keep, like, contacting you and emailing you.
No, I'm gonna, no, I'm done. I'm done with you. No, I'm available. I'm available, yeah. Yeah, maybe we should put together a sort of a, every once in a while, on the internet, study, a few questions, something like that. Sure.
So if we want to do our practicum with you, how do we do that?
Well, we have now practical students now. Tomorrow. So you let me know that you're interested. And are you thinking of the physical assessment and the 100 patient cohort now?
80 right now.
That we can do before the university finishes. So once she's done with her 80 hours, then we can arrange that.
Okay. Like it, I mean, I would.
So you would like a stop there?
If I transition jobs again, I would be coming back down to El Paso, so closer.
Oh, yeah, we can do it.
So it's either 100, 400 that I would have to do.
Well, that's also, there may be ways to work that one out. Because we have a prescribing psychologist in Santa Teresa. And she has a physician who is willing to provide supervision.
Oh, you got you? Yeah.
Are you?
Okay, actually, I don't know.
Okay. No. Are you familiar with a place down the curve? The name of the road is escaping me. Yes, it could be something solutions. I'll find out the name.
Okay.
But they're actually looking for like, and they have a physician who's willing to supervise.
Good evidence.
So I'm trying, it's my farm via hospital. And passing.
Thank you. We'll be on the
Yeah, that's it.
I mean, if a
That's
physician's
also a side
willing to
thing.
do it.
So one of the things that I want to do when I get through this process is I want to help, like, setting up practicums and, like, I want to support programs. I want to get all that stuff, like, more situated. Like, that's why I came to New Mexico, is because I felt like this has been in place a long time. They'll have this shut together. They'll be doing it really well.